I want to welcome everyone. So I'm Doug Wood, the chair of the Department of Surgery, and hopefully most of you know that. And I want to welcome everyone to this year's Harkins Surgical Symposium. And just before we get started, I want to acknowledge the land that we are having this meeting on. I'd like to acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, and honor and gratitude this land that they give us the privilege of working and living on. This is also a highlight of our department. This is a highlight of the year to have this surgical symposium, which is a chance for us to celebrate the work that's going on in the department, celebrate the faculty that we have, and see some of what's going on around the department. And this is always something I look forward to, that we set aside the day for, and is one of the most important days that we have in the year. We always focus on one of our divisions as well, and this year we're focusing on the Division of Trauma, Burns, and Critical Care at Harborview. And we're going to have a chance to hear from many of those faculty, and we had a roundtable with the faculty and fellows and residents yesterday with Dr. Cornwell. So we'll be highlighting Harborview, but also obviously be having presentations from other parts of our department. And of course, we are all dealing with a challenge of COVID. We're working to pivot to being able to have a virtual Harkins Symposium. And please give us a little bit of grace if we make mistakes or if it doesn't all go perfectly. We think it's going to go perfectly, but this is the first time we've held a virtual meeting. And I just have gratitude that we are able to do this, that we're actually able to still meet together and have this kind of day together, even if it's not possible for us to all be physically together in an auditorium. And I want to welcome Dr. Edward Cornwell, who is our 71st annual Alfred A. Strauss Lecturer, and we'll be hearing from Dr. Cornwell a little bit later in the Harkins Symposium. And then, of course, the highlight of the day is the Alfred A. Strauss Lecture this afternoon that Dr. Cornwell will be giving. And I'll give a bigger introduction about Dr. Cornwell and our appreciation for him being here at that time. So, Dr. Cornwell, thank you for joining us. And I also want to give you a little bit of grace. We're so glad that you're with us for the Harkins Symposium, which would be normally what you'd be doing. I want you to feel very open to commenting on any of the papers presented. I also don't want you to feel obligated to comment on every paper presented. There might be some that you had to step out for, or that that you don't have a burning question, and we have plenty of others that can ask questions and make comments. So I just don't want to put an additional burden on you. So I'll close my welcome with that. We're excited about the day, about the Harkins Surgical Symposium that we're starting now, as well as the Strauss Lecture, which will be this afternoon, and Dr. Cornwell visiting us. And then I'll close with just appreciation to Allison Fiddler, Savannah Tam, who have really worked on the organizational aspect of this. They've been the brains behind making this work. And then Peter Wu, who year after year organizes our Harkins Surgical Symposium. So thank you to them. And I'm going to turn things over to Dr. Wu to get us started with the first session.
Well, good morning, everyone. And thanks, Doug. I'd like to first also recognize Ellison and Savannah for their extraordinary efforts to organize our first virtual symposium. We certainly could not have pulled this off without both of you, so thank you very much. I'd also like to thank the 20 faculty members who offered to participate in our virtual experiment, which enables us to continue our Harkins tradition in spite of the pandemic. In the spirit of the Harkins Resident Education Symposium, I encourage all of our webinar viewers to submit questions anytime during the presentations via the chat feature, and use it through your meeting controls bar, which will raise a chat window, and you can directly type in a message, comment, question, and the moderator will collect the panel Q&A, and we will answer those during the Q&A sessions following each group of speakers. So without any further delay, I'll hand things off to Dr. Joe Cuscieri, the next San Francisco General Trauma Director that we will be recognizing next year. But for now, we will hang on to him, and he will be doing the introductions for the Harborview Division. Thanks.
Thank you, Dr. Wu, and thank you, Dr. Wood, for the introduction. And thank you, Dr. Cornwell, for joining us today. And I look forward to both your lectures later on today. It is my honor and privilege to actually introduce the next several series of talks, really focusing on the work done at Harborview Medical Center and really truly national, international experts in the area. The session will be divided into two different components. One, which will be starting off looking at healthcare delivery, and then followed by the next session within this component, really looking at specific management of injuries. Our first series of talks will be given first by Dr. Barclay Stewart, who's an assistant professor of surgery. He's internationally known as an expert in global health, and really is going to focus and give us some of his research surrounding the healthcare delivery within Ghana as how they affect injured patients. Our second talk will be given by Dr. Eileen Bolger, who is a professor of surgery. She's the chief of trauma at Harborview Medical Center and holds one of the most prestigious roles in American surgery in regards to trauma as the chair of the American College of Surgeons Committee of Trauma. And she'll be speaking to us on something that has really become evident and really has been the hallmark of how to manage COVID-19 and how our regional response actually contributed to the management of our critically ill patients in our region. And this will be followed then by Dr. John McLean, who is currently a fellow in our Burn Trauma Critical Care Fellowship at Harborview Medical Center. Dr. McClellan, actually, we were fortunate to have him as our first military collaborative with our military civilian participation last year as a general surgeon. He stayed on to do a fellowship with us over the course of the year with our relationship with Madigan. And he's going to be specifically talking about the military civilian partnership and how it relates to trauma preparedness, both for civilian as well as military trauma. And with that, we will start off with Dr. Barclay Stewart.
Thanks, Dr. Cuscieri, and welcome again, Dr. Cornwell. It's nice to see you this morning. Thanks for the first case start. I'm going to talk about the National Health Insurance Scheme in Ghana and how it affects trauma care delivery, mortality, and catastrophic health expenditure. And this is work done by myself and my two mentors, Dr. Charlie Mock, based at the Harborview Injury Prevention and Research Center, and Adam Jadu in Ghana. Savannah, is there a way to advance the slides? Perfect, thank you. We'll highlight an example of this arch of research within our UW Global Surgery program. And then we'll also identify some opportunities to strengthen the health insurance scheme and improve care for the injured in Ghana. So this is the World Health Organization Universal Health Coverage Framework, and it aims to illustrate how we should take existing pooled funds and expand coverage to people within the population, services that are covered for those people in the population, and then reducing cost sharing and fees for that service delivery. Ghana set out to do just that in 2003 with the rollout of the National Health Insurance Scheme, which aimed to cover most conditions that ail Ghanaians. It was commended by Mr. Gates, as you see in this photo, commenting to President Mahama. about how progressive this effort was and steps toward universal health coverage. The model was further after rolled out for a few years, describing this Lancet piece as a model for Africa and Asia. And in fact, now, over 15 years since its inception, covers about 13 million people, which is about half the population of Ghana, and facilitated increases in the per capita health encounters, which started at 0.5 per capita per year in 2005 and are above 3 per capita in 2019. And the health insurance scheme covers most of trauma care, although not everything. It doesn't cover many medications, advanced diagnostic imaging, prosthetics, rehabilitation, and services for the deceased, for instance. And the impact of the health insurance scheme on trauma was relatively unknown as we started out on our arc of research. So our initial plan was to start out with a capacity assessment, which led to us uncovering some challenges with the health insurance scheme and how it reimburses hospitals, and ultimately how those costs are passed on to patients and how that affects them and their families. And we'll talk about those studies briefly. We're going to present a good bit of data. The point, though, being the arc of the research, not so much the actual data themselves. So in response to the 2015 World Health Assembly resolution on emergency and essential surgical care and anesthesia, we followed the mandate to perform assessments of the current capacity globally. We sampled 40 hospitals countrywide in Ghana and gathered data on the availability of essential trauma care resources and services. This is just an example table of the resources for surgery, where 0 is resources that are not available, 1 is available to less than half of those who need it, 2 more than half, and 3 always available. These are medians and ranges. And the take-home message for both this table and the others that accompany it were that all levels of the health system had hospitals with major gaps, particularly in essential and general surgery, damage control surgery, and fracture management. For each resource and service that was rated less than 3, we followed up with questions and more in-depth investigations on why those deficiencies existed. In general, a lack of planning and high cost of resources, insufficient training, and fragile supply chains were frequently encountered, but also cost-sharing requirements or user fees. And as we untangled these challenges even further, we realized that the National Health Insurance Scheme reimbursements to hospitals were both insufficient and delayed, and that severely limited hospitals' ability to provide essential trauma care to patients, particularly without passing cost on to the injured. The total claims of payments in 2005 were about $8 million and have now risen in 2017, was the last published data on this, to about $1.1 billion. And the annual deficit in 2019 was about $300 million. So despite being touted as an unfragmented example of how nationalized financial risk protection in sub-Saharan Africa could be modeled, there's been a decline in both reimbursements in terms of the rate and the timeliness of their payments to hospitals due to an over-reliance on a narrow tax base, a large informal work sector, and a greater than anticipated utilization of the healthcare services. So as a result, the resources and incentives necessary to provide essential services to patients have become unavailable at many health centers across the country. And those costs associated with care are now being passed on to patients. So we then hypothesized that this exacerbates poor service delivery and can ultimately lead to increased rates of mortality and catastrophic health expenditure for the injured. So we sought to dive a little bit deeper into the financial experiences of injured patients and families by sampling injured patients at one of the country's largest trauma centers, or Komfanoche Teaching Hospital in Kumasi, Ghana. The hospital has significant trauma and burn care capabilities and is a real hallmark in trauma teaching in West Africa. But the service delivery is hindered by poorly planned and organized care and significant cost sharing, at least by anecdotes. Although this picture is how the hospital and the government sees it. Advance, please, Savannah. This is how the public sees it. Advance one more time. With ATMs at the front gate indicating its need for cost sharing. So we sought to understand the impacts of the health insurance scheme on catastrophic health expenditure and mortality after injury at Komfanoche. And one more advance now. Thanks. So catastrophic health expenditure is commonly defined as the expenditure for medical treatment that poses a threat to the viability of households and ability to maintain its subsistence needs. The accepted threshold for this is about 10% of the annual household income, although other thresholds have been presented, and we mark those with sensitivity analysis. We sampled 1,600 consecutive patients who required surgery for injury as a marker of injury severity. Catastrophic health expenditure was common among non-insured patients, particularly at this 10% household income level, where about 60% of patients experienced catastrophic expenditure. However, what was shocking is that 50% of all patients, including, half of NHIS insured patients also experienced catastrophic health expenditure. And not unexpectedly, but contrary to the intent and spirit of universal health coverage, catastrophic health expenditure was commonly experienced by households in the lowest income quintiles. Additionally, nearly half of people in the middle quintiles and a quarter of people even in the highest quintile experienced catastrophic health expenditure after injury. The health insurance scheme is designed to cover children through an opt-in program with a very minimal premium. However, we found that about a third of children didn't have any insurance. And at the 10% annual household income threshold, about half of families with insured children and over 80% of families with uninsured children experience catastrophic health expenditure. Insurance status was not associated with difference in mortality. I know this is very different, Dr. Cornwell, compared to what you've experienced in your research with your colleagues here in the United States. And we postulate that there are so many trauma care resource and service deficiencies along the spectrum of this ad hoc trauma system that affect injury-related mortality. And mortality, therefore, is high regardless of insurance status in Ghana. And as the trauma care capacity improves, the impact of health insurance on outcomes might be unmasked. So our conclusions from all of these data were these. First, low health insurance scheme reimbursements limit hospitals' availability to provide essential services, including trauma care. The health insurance scheme provides some degree of financial risk protection for all patients. However, more than half of patients and families experience catastrophic expenditure regardless of insurance status. Poor families and families with children more commonly experience catastrophic health expenditure, particularly for those that are not insured. And health insurance currently does not affect mortality yet, and might as capacity improves. So our recommendations to the National Health Insurance Scheme after all this work include covering the entirety of essential trauma services to avoid catastrophic expenditure among injured patients. This includes things like blood product transfusion, diagnostic imaging, prosthetics, rehab, palliative care, and mortuary services, which currently are not covered. Next, to increase child enrollment through evidence-based opportunities like leveraging school system, healthcare encounters, and community health workers, and potentially even increasing the revenue to the NHIS by transitioning to an opt-out scheme with sliding scale premiums based on household incomes. We should eliminate cost sharing for emergency conditions and services, particularly when patients don't have the choice to or whether or not to receive care. And then ultimately support designation of trauma centers to couple volume and quality of service delivery and decrease the cost benefit ratio, which might ultimately add value to both patients and the National Health Insurance Scheme. So thanks very much. We, again, are glad you're here, and thanks for your time.
Yeah, the unmute button is very important. So thank you, Dr. Stewart, for that really excellent presentation, and Dr. Hushari for that introduction. Really delighted to have just a few minutes to talk with you about what I think is a very important topic. As you know, we're all still in the midst of this pandemic and learning as we go about how to deal with it. And I think we've seen that across the country, there's very variable response to how states and healthcare systems have managed the situation. And I want to share with you our experience in Washington State, because I think it's a potential model that could be adopted around the country. Can I have the next slide, please? So my objectives are to talk about regional coordination for the COVID response, why that's important. I'm going to introduce the concept of a regional medical operations center, and then how I think those can be put together fairly easily across the US. Next slide. So when you think about mass casualty response as a trauma system, we're used to dealing with that. We have events, not uncommonly, where there are multiple injured patients or multiple burn patients, and we have a system in place to deal with that. We at Harborview serve as the Disaster Medical Control Center. We stand up in those situations very quickly. We communicate with EMS, and we're able to distribute patients as needed around the region. The challenge, of course, with the pandemic is it's not exactly the same scenario, right? We have, normally in a trauma event, it's a discrete event. It's time limited, it happens, we deal with it, and it's done. And we have established infrastructure to deal with it. We have trauma centers, we have a system of triage, we have a mechanism to move patients around the system very efficiently. And while it requires a surge in the hospital, in both the ED, the ICU, and in some cases the OR, again, it's a time limited and manageable situation. And the pandemic challenges us because it's an ongoing problem. It covers broad geographic regions, so everybody's impacted. All the hospitals are involved, not just the trauma centers. And it requires a very prolonged ED and ICU surge. And on top of that, we have to manage the risk to healthcare workers. So we have to adapt our mass casualty response to deal with the pandemic. Next slide, please. So this is a map of our trauma system in Washington State. We have an inclusive trauma system. We have actually 80 designated trauma centers in the state, a limited number of level 1 and 2 along the I-5 corridor and in Spokane, but a large reach into our rural parts of our state where we know trauma mortality is quite high by engaging smaller and critical access hospitals in that response. So these hospitals are used to working together for trauma patients and moving patients efficiently through the system, and we leverage that to deal with the pandemic. Regional coordination is really important in managing any large event because it gives you situational awareness. It gives you the opportunity to collect data from all these hospitals and know what's happening in real time. As we've seen the pandemic evolve in Washington, initially affected largely King County in Western Washington, where a large proportion of the population lives in closer proximity. But then we saw a huge outbreak subsequently. Can you go back, please? In Yakima. Which is a much more rural part of our state and needed a lot of support. So being able to track the pandemic with situational awareness is critically important. It's also important to be able to distribute patients among hospitals, and I'll talk more about this, but being able to sort of level load the hospital system becomes critically important in allowing an adequate response. Also, you can manage your pre-hospital care resources through a regional coordinated approach. If you have alternative care locations set up, which we had for a while, you can manage triage and transport to those facilities as needed. You can ensure that you're paying attention to the non-COVID patients, the other emergencies that we deal with, particularly trauma, but also cardiac arrest and stroke. There are specialized centers for these where you need to preserve some capacity. You can also work as a community to come to consensus on crisis standards of care should you have to implement them. And you can identify outbreaks in high-risk populations. So there's lots of advantages to thinking about a regionally coordinated approach. Next slide, please. And if you think about the three main groups that need to come together and work in a coordinated fashion over a long period of time, it includes public health for contact tracing, identifying outbreaks, managing high-risk populations, emergency management, again, for dealing with moving patients over sometimes long distances, and then our acute healthcare system. So we need to find a way across the entire country, really, to bring these three groups together to work consistently over a long period of time. Next slide. So the approach that we're advocating is a regional medical operations center. It's not a new concept, but it's variably established. Most of them have been built on the framework of the emergency care and trauma system. There are some that are very well developed and very well funded, particularly in Texas. And really the essential elements around them are that you upfront get formal agreements with all of the hospitals, healthcare systems who are normally competitors, but you get them to agree that they're going to collaborate, they're going to share data in a crisis. You have a mechanism to get all of those major stakeholders in a room, whether that be physical or virtual. You have strong communication strategies to your emergency operations centers. Fault-tolerant communication systems are critically important. And then you need a software platform to be able to really track that situational awareness, which I'll talk more about. So the idea is that you could, in a disaster, you could scale up your normal trauma emergency care system to a regional medical operations center. The other term that's used is a medical operations coordinating cell. That's a federal term. But but either way, they're the same thing. Those would then integrate with a local emergency operations center, could link to a state center, and then that data could eventually roll up to a federal system. And really that would be the ideal. If we could establish this across the country, we would have situational awareness across the entire US consistently. Next slide. So what we did in Seattle, as I mentioned, Harborview, we're the Disaster Medical Coordination Center. We recognized very quickly that that infrastructure was not sufficient to manage the pandemic. And working with the Northwest Healthcare Response Network, which is our healthcare coalition for disaster response in the region, we came together quickly and formed what we call the Regional COVID Coordinating Center. This is led by Steve Mitchell, who's the director of our emergency department, and a number of people were heavily involved in putting this together. It's become critically important and now has been adopted as a statewide resource. Next slide. And I just wanted to share with you sort of the framework for this activity. We did publish this experience in JACS just a couple months ago, so the paper is available online for free. But really the coordinating center has 2 surveillance pillars and 2 coordination pillars, and I'll talk about that. Next slide, please. So on the surveillance side, as I mentioned, it's really collecting data. So we have a software platform, which I'll talk about, that allows us to collect data from all the hospitals, now statewide, that gives us not only bed availability and number of COVID patients that they're dealing with, but also any staffing issues they have and their resources. So when we're short on ventilators or PPE, we know where we're short and where things can be distributed. And then the other critical importance of this, which ties in with public health, is our ability to surveil high-risk populations. So we know that outbreaks are common in long-term care facilities, alternate care facilities, jails, prisons, shelters, and so we can monitor that situation. We also have 2 coordination pillars, and the most important one really is the health system level loading pillar, which allows us to move patients from a hospital that might be getting overloaded from a nursing facility near it, to decompress that hospital and get patients to where they can get ideal care. It also allows us to move resources around, such as PPE and ventilators. Next slide. So early on, we actually have a software platform that we had originally developed as a homegrown system, but it wasn't sufficient for the scope of the pandemic. So we worked with Microsoft, who happens to live in our neighborhood, and they offered us this, to very quickly, within about 2 weeks, developed a product for us, which they are now offering free to anybody around the country who wants it for their regional coordination. But it's a very nice system where the hospitals can enter real-time data on their staffing, their beds, their equipment, and their burden of COVID patients. Next slide. We also have now expanded that to collect data from long-term care facilities, so we can do uniform testing and identify outbreaks before they occur by tracking percent positive patients, percent positive healthcare workers, and PPE availability. From a logistics standpoint, we needed a little bit of stuff and a little bit of space, so we commandeered a room in the mailing building. We put some computers in there. We repurposed some of the staff from the operating room at the time when we weren't operating in the PACU to staff. This is a 24/7 call center with backup from physicians, both from trauma surgery and emergency medicine. And this allowed us to be available as a one-stop stop for any hospital that needed to move patients across the state. Next slide. We have tried to move this concept nationally. So we, working through the American College of Surgeons, published a document on how to set up a regional medical operations center. We actually sent that to all of the major city and state officials through the ACS advocacy team early in the pandemic. We've also worked with the federal government, which, can you go back, please? Is the Assistant Secretary for Preparedness and Response, developed a toolkit and funding mechanisms for this strategy, and that's available on their website as well. It's the Asper Tracy website. So to summarize, I think that we've learned a lot in a few months about the critical importance of regional coordination in our ability to not only manage the pandemic, but really preserve the function of our emergency and healthcare system. It's allowed Harborview to continue to manage trauma without any interruption. The regional and hospital infrastructure that's really built to support a trauma system or a mass casualty response is a really good place to start. And I think that surgeons can play a really key role in the leadership to this response. So I want to thank you so much for the opportunity to share that with you. Look forward to the discussion.
Hello, everyone. I'm Major John McClellan. I'm here to speak on the role of military-civilian partnerships for trauma readiness. Thank you for the opportunity to speak today. Just a little background about myself. I'm a Madigan, 2019 Madigan General Surgery graduate. I started working at Harborview last fall as part of a military-civilian collaboration with Lieutenant Colonel Brian Beldowitz. I deployed this past spring as a general surgeon with the Joint Medical Augmentation Unit out of Fort Bragg, North Carolina. I returned in July and just recently started a surgical career fellowship here at Harborview. I have no disclosures. I think it's important to step back and realize that these military-civilian partnerships are not a new entity. Throughout the past century, there's been a few pinnacle moments that have been important to these partnerships. So the first were the Red Cross Army base hospitals in World War I and World War II. Specifically, these hospitals were set up to treat returning casualties for World War I and then also mobilized in World War II to European and Pacific theaters to help treat casualties overseas. The next pinnacle moment was in the Gulf War. After the Gulf War specifically, they demonstrated significant medical readiness gaps within our trauma faculty that had been deployed. This drew a lot of criticism from internally within the military and externally from the government and how we're actually training our military providers to take care of wounded soldiers. Colonel Donald Trunke, who I'm sure everyone listening today is familiar with, was one of the first to really offer insightful perspective on this issue in his 1993 Archives of Surgery publication, Lessons Learned. Here he highlighted the necessity of maintaining the currency of trauma care for the military surgeon, was quoted saying, "Train as we would fight." Next slide. With Dr. Trunke's testimony, along with other outside opinions, and the government sought to expand the military training programs at civilian hospitals. This led to the first Joint Tri-Service Training Program at Bentop Memorial Hospital in Houston, Texas. This was to train physicians, nurses, and medics prior to any combat engagements. This slowly led to the next development where each service began to develop their own military-civilian collaborations in response to the Iraq and Afghanistan wars in the early 2000s, where the Army at Miami-Dade Ryder, Navy at LA County, and Air Force developed programs at Shock Trauma, St. Louis, and University of Cincinnati, all of which are still in progress today. Next slide. I think additionally, it's important to highlight the path of a military surgeon to really understand why it's important to have concentrated high volume practice while we're stateside. So only about 1/3 of general surgery graduates coming out pursue fellowship, and that's directly out of residency. That's compared to about 2/3 of our civilian counterparts. The most common fellowship in the past 4 years has been surgical critical care. We usually deploy within 3 to 9 months of graduation. That's either from residency or fellowship, with plenty of examples of people deploying within 1 month. The majority of these surgeons coming out of residency will be assigned to a forward surgical team. And that's a kind of a back one slide. And that's with the FST or the newer FRSTs. And this includes 2 general surgeons, 2 orthopedic surgeons, and 2 ER doctors. Typically, however, these teams are usually split in half, especially in Afghanistan, and they're entirely separate bases. So really from a surgical perspective, you're stuck with, not stuck with, but you have a general surgeon and an orthopedic surgeon, and usually they're relatively new grads. Additionally, these teams, as the general surgeon on the team, you're typically the guy who's organized or has the most experience in organizing the team. You're in charge of training the nurses and medics who also may have limited recent clinical experience. And additionally, you're all responsible for all the trauma and surgical care of that team. Next slide. The number of deployed cases vary while you're gone. This can range from 0 cases in 9 months to 300 to 400 cases in 3 or 4 months. It just depends on your location, rules of engagement, and their overall time of year, actually. When you return, the dwell time, which is your time at home, is usually about 9 to 24 months. And this depends on your rotation. In that time, you're responsible for developing your elective practice, regaining your surgical skills if you had a slow deployment, all your academic productivity, your administrative duties, and then re-preparing for the next deployment. And obviously, most importantly, spending time with your family. The average number of cases of an Army surgeon, this is looking at self-reported data from a survey I'll talk about in the next slide. But the total number of cases that were self-reported, the average was 124. Of those, 12 were operative trauma, 4 were vascular, and 2 were thoracic. This obviously has a significant range for people who do less than 10 cases a year to people who do 500 to 600 cases a year, just depending on where you're at and what type of practice you have. Next slide. The survey was a recent survey this past year sent out by the consultant of the surgical consultant for the Surgeon General, looking at the opinions of military physicians. This polled all active duty Army general surgeons, chief residents, and fellows. And the simple question was asked, do you feel capable of taking care of a severely injured, wounded soldier on deployment? And while we want this number to be 100%, only 5% answered straight no, and 25% were undecided. And undecided left a lot of comments saying, I would feel comfortable if I had some sort of train up prior to my deployment. Another question that was asked is the interest in military-civilian partnerships. And over 3/4 of respondents were interested in some sort of military-civilian partnership, either in trauma care or within their own specialty. Next slide. One of the challenges of maintaining medical readiness is really defining what we're supposed to be able to do as general surgeon. What are we responsible for? The Joint Trauma System did this by developing the knowledge, skills, and attitudes, also known as the KSAs, using data from a combination of the Joint Trauma System clinical practice guidelines, the trauma registry, and references such as war surgery to really, next slide, to really identify these things that we should be responsible for. These are very comprehensive, and meeting a lot of these requirements would be very difficult. And a lot of them are outside the scope of practice for even a civilian trauma surgeon. But the goal is that we can complete these through simulation, skill-based learning platforms, preparation prior to deployment, and most importantly, and why I'm here to talk today, is the military-civilian collaborations. Next slide. As I mentioned, since the early 2000s, the partnerships have continued to expand greatly. This is a map of the largest known trauma partnerships, not including local partnerships and other off-duty employment agreements. The largest academic centers are marked in red in Pacific Northwest. We have OHSU and obviously Harborview. And the green are the largest Army bases and hospitals that also include a lot of special operations forces that do partnership with civilian hospitals as well. And obviously San Antonio in Texas is marked in purple, the only level 1 trauma center in the military, as well as the Army Medical School and Training Center. It's important for these academic centers and trauma centers to be in close proximity to these large bases to facilitate people actually getting to the center and reduce the amount of resources needed to make that happen. Next slide. The way I see it with the military-civilian partnerships is that it's really a symbiotic relationship between the two. And we've already seen that here at Harborview. You integrate the experience of a knowledgeable and experienced trauma and civilian trauma and critical care surgeon with the military physician. May have a different perspective on austere treatment of casualties as well as extensive war injuries. The collaborative research is another major benefit of this relationship. This includes not only the benefits of academic productivity, as well as access to Department of Defense research money. Medical education is something that we've done here well at Harborview already. We have set up asset best and emergency war surgery courses at Madigan that University of Washington residents come to join us, and Harborview staff help teach. So this is something that I'm excited to help to continue to expand. And obviously at a lot of high volume trauma centers, it can be overwhelming to meet that demand. And the military members will get experience and expand their medical readiness at the same time offloading some of that work from those centers. Next slide. The way I see it for the future of this partnership, and this is not just obviously my opinion, but it's also from formal military guidance and working with the civilian trauma centers, is to continue to establish embedded personnel at these sites. So currently it's just myself and Lieutenant Colonel Brian Beltowitz, but ideally we'd have full-time academic and clinical responsibilities here and serve as military liaisons and educators to those facilities. And then we add medical specialties such as emergency medicine, anesthesia providers, as well as orthopedists, and hopefully progress them to full-time and better personnel. The goal will be then to set up medical rotators, so military people. So this is people coming from 1 to 6 months that come here to get some trauma experience coordinated by the embedded personnel, and hopefully we'll get to try to maintain that medical readiness. And this will be kind of rotational based from the local military bases. And again, once again, like I mentioned before, expand the medical training. So the military does have a lot of resources for cadaver and simulation training. And it would be great to bring those types of things to the civilian hospitals. Next slide. I want to thank you for the opportunity to speak today. I guess we'll take questions at the end, but feel free to reach out to me at my email that's on the slide there.
Well, thank you. Those were a series of excellent talks. We'll open our question and answer session now, and you can use the chat function for any questions or comments that you may have. Seeing none as yet, I do have a few questions I'll start off with. And to Dr. Stewart, you really excellent talk. And my question to you is, one of the things that was not, at least I didn't see factored into the evaluation of patients who were treated in terms of you really focusing on inpatient components following their injury. What about the long-term effects and the long-term continued care for these injured patients and the potential cost associated with that, which really will lead to further problems in terms of their ongoing social economic status?
Yeah, thanks, Dr. Kishkari. We totally agree, and the fact that rehabilitation is not considered as part of within the coverage plan of the insurance service certainly has been concerning, and we've advocated for its inclusion, particularly since a lot of the gains that are achieved through improvements in trauma care capacity certainly would not be consolidated without rehabilitation care. So we're on the same page and working to see if we can get those included.
Thank you. Let's see any other questions. If I could follow up with Dr. Bulger as well too, in regards to getting this all organized is a huge effort. And as this goes out to further areas, especially where there are HMOs and PPOs and other insurance deliberated care in terms of maintaining people in their own system and not transferring patients out of their system, how do you see this being played out in potentially other areas, especially getting that whole buy-in?
Yeah, the buy-in is critically important. I think, never let a good crisis go to waste, right? So people know that when they faced this first wave of the pandemic, how much stress their system was under. And I think pretty quickly realized that they were going to have to work together and collaborate in order to just make it through that. The way we've dealt with competitive healthcare systems is first, if people want to move patients within their own system and they can accommodate that, that's fine. We let them do that. But they know that we're there for them when they can't do that anymore, which happens fairly quickly in a big surge. So, we're not disturbing their ability to move patients up front, but we can offload them when they are overwhelmed. And the agreement is that everybody will share the data openly and that everybody will accept transfers when they're assigned to them. So if we see that, we have to decompress a healthcare system or a group of hospitals in Yakima, for example, we can look at the capacity in Seattle and we can say, you're going to take 3 and you're going to take 3 and you're going to take 3 and they're going to take them. And that works quite well in sort of evening out the load.
A follow-up question in terms of that from Dr. Wood is, as we initially experienced this first surge and you put this all together, what are the anticipations as we enter the fall, winter months with influenza being a problem and potentially a second surge with social distancing decreases? How do you see this playing out?
Yeah, so of course we're all worried about, another peak of cases. We're already starting to see increased case transmission in the community. We don't know what influenza is going to do on top of that. Of course, we're encouraging everybody to get their flu vaccine to try to help minimize that risk. But I think that we're in a little bit better shape than we were at the beginning of the pandemic for a couple of reasons. One, in that we have this infrastructure established now statewide, which really allows us to move patients over even broader distances than we could previously. And obviously we have more treatments now than we had in the past for COVID. So we'll hear from Dr. Robinson more about sort of COVID ICU care and what we've learned there.
Thank you. Just to make sure we get to all panelists, Dr. McClellan, one of the questions that is brought up by Dr. Wood is, as you developed this current partnership, what challenges did you recognize, or did we recognize, and how do we make things better as we move forward?
Yeah, that's a good question. One of the challenges we had were actually from a legal standpoint of having military members working in a civilian hospital. There's also a lot of different entities within the military that have their hand in trying to get people at academic centers, and sometimes the communication between the groups is difficult. So when you talk with one group in the military, they have their own agenda, and another group in another military. So I see that one of the biggest concerns with setting up, I think we have a pretty good handle on it here, but other academic centers, is the confusion that goes along with bringing military members to this sites, I think, is the big problem. And I think there's more of a coordinated effort now within the past 6 months than there has been before.
I can comment on that briefly, Joe, too, because we've been working hard on this for about 3 years now. I think we are in a good place now. We have a signed training agreement. We've worked through all the legal issues. We've really emphasized the importance of partnering with Madigan, who we already trained their residents, and have a wonderful relationship with them from a training perspective. So we're close, I think, to the point where we can start to integrate a full forward surgical team here and bring in all the other team members, which will be exciting.
To ask a question, which I don't know that we have a great answer to, but from Dr. Mayer to Dr. Stewart, how do you see what you've learned and gained in terms of experience from Ghana, and how could you incorporate some of those things into our own U.S. healthcare in terms of providing care to all?
Yeah, thanks, Dr. Mayer. So a few things. I mean, the first is from examples from the UK, Australia, and Holland, for instance. We know that universal coverage and very low out-of-pocket cost without cost sharing leads to the best performing health systems. In addition, it's important to strengthen the reimbursements for essential services like primary care, trauma care, obstetric care, et cetera. And when there's a prioritized population health increases, that's been seen several times across sub-Saharan Africa and countries that have started universal health coverage plans. But I think it's important that we streamline the reimbursements from health insurance schemes of single payers to hospitals and the staff that run them to ensure that care is delivered comprehensively. And when that breaks down due to a poor tax base and or overutilizing healthcare, then the whole system fails as it currently is in Ghana. And then ensuring that the safety net conditions and hospitals and services are well reimbursed and protected, which again helps reduce disparities and ensure that people get the care that they need.
I know we want to try to stay on time. I know there's several other questions that are coming through, but in the interest of trying to stay on time, feel free to reach out to all the speakers later today. I know they'll be anxious to answer any other further questions too as well. But in the interest of time, we'll move on to our next series of talks. Thank you all. Great talks. The next portion of what we're going to talk about in the next component is really focusing on specific areas of trauma and burn care. And in these next series of talks, our first talk will be given by Dr. Bryce Robinson, who's an associate professor of surgery. He's the associate medical director for critical care services at Harborview Medical Center. He is nationally known as an expert in trauma and critical care management and has done a fair amount of research in this area. He's going to spend some time talking about how we had to reconstruct sort of our ICUs for COVID and what we learned from that. This will be followed by Dr. Samar Bobby, who's a professor of surgery. He's the acute care section head at the Injury Prevention Center and the program director for our critical care fellowship at the University of Washington. His focus for a long time has been on geriatric management. He's going to focus his talk on rib fracture management in the geriatric patient population, which has been an ongoing area of interest for a number of investigators here at Harborview for the last several decades. This will be followed by Dr. Deepa Kanir, who's an assistant professor of surgery who completed her fellowship here, and we were able to re-recruit her after she left to Boston to Brigham's and Women to join our faculty last year. She has developed a progressive interest and become nationally recognized looking at long-term outcomes following injury, and that's what she'll focus her talk. And our last talk from the trauma burn group will be from Dr. Sam Mandel, who we've been fortunate to have for many, many years as a resident fellow and stayed on his faculty as an associate professor of surgery. He is nationally known as an expert in clinical management of burns, and he'll be talking about new and innovative things around burn care. And with that, we'll start off with Dr. Bryce Robinson.
Thank you, Joe. I do want to keep everybody on time, and I really appreciate the introduction. I was asked to talk about COVID care in the ICU. I know a lot of people in the Department of Surgery have worked really hard for implementing and having a strategy for COVID care, especially since it hit Washington first. And I will spend about 10 minutes talking about what we've done in the ICUs. Next slide. I don't have any disclosures. So we're going to talk about the CDC concept of space, staff, and stuff. We're going to talk about the good stuff for COVID, and we're going to talk about the bad stuff for COVID. All right, so space first. Oh, next slide. All right, so I think the premise of COVID care in the ICU really comes down to, is your patient or is your not patient going to generate aerosolized particles? And specifically for our ICU patients, we're going to focus on mechanical ventilation. If your patient has a high risk of an AGP, they need to be in droplet and airborne precautions. At Harborview and at the University of Washington, we've worked really hard to have as many ICU beds in a negative airflow situation as possible and to congregate our COVID patients so there's efficiencies of care, efficiencies of safety for donning and doffing, and et cetera. But the reality at the university and both at Harborview is that not all of our beds are negative airflow. And if you talk to those in New York City and New Orleans and Houston, we really got overflow of ICU patients, you have to put these patients somewhere. And so the reality is that our operating rooms are not negative airflow, our emergency departments are not negative airflow. As much as engineering can work magic in our ceilings, 30% of the critical care beds at Harborview cannot be placed in negative airflow. And ultimately, and what we're finding at Harborview is that the surgical needs or the trauma needs of the patient outweigh the medical needs for their COVID care. And so even though you may have a negative airflow in your surgical ICU bed or in the medical bed, you're going to put them in a surgery ICU because, again, their more pressing needs are surgical or traumatic in nature. Next slide. So like most hospitals, you have an ICU service and they go to a very specific part of the hospital. And so bed placement is really via service line. Next slide. I think it's important to understand and to socialize that as surge capacity goes, that there's going to be a stepwise of growth. And for the Department of Surgery, it's really important to understand is that your surgical patient may be in a non-surgical floor. And if a surge really occurs in large capacity, your surgical patient may be in a very non-traditional ICU environment. For us at Harborview, we quickly expand to our PACUs, we'll quickly expand to actually operating rooms. And then when it gets really bad, phase 3, where we're almost doubling our capacity, we're looking at putting ICU patients in angiography or gamma knife and other areas which are really non-traditional. Again, it's a stepwise approach depending on the capacity and the number of inflow of patients. But I think it's important for people to understand that in these really extreme times, your patients may not be in that traditional surgical ICU that you've become accustomed to. So let's talk about staff a bit. Next slide. I think it's important for the Department of Surgery and for all medical providers to understand that you're going to be reorganized, that the multitude of offline staff, so if services are becoming offline, surgical services specifically become offline because of capacity issues, those physicians and care providers are going to be placed into a pool. It's also important to have a pool of providers because we expect providers to become ill with their own disease patterns. And so we really need a bench to have providers come and provide care. The goal from SCCM and the goal at the university as well as Harborview is really a tiered staffing model where we'll have one assigned intensivist to about 12 to 16 patients. And that, again, those patients can be anywhere in our various environments. Who else will fill in the pool? Well, we expect fellows, residents, and APPs, and that's pretty traditional for us. But what is non-traditional is non-intensive care physicians filling in the gap. So a GI doctor, psychiatrists, dermatology physicians, really helping out and becoming part of our critical care teams. Next page. So instead of going into the service-based line, I think it's important for people to understand that we would go to a geography-based critical care system where bed placement is really based on what bed is available regardless of the intensivist at the top of that pyramid. For Harborview, this is our system right now that as we expand in a stepwise approach, each little floor or entity will have an intensivist at the top and then get backfilled with, again, that pool of GME resources, attending resource, APP resources, and that there will be certain intensivists with expertise to help out the entire pool of ICUs. The surgical ICU probably have surgical patients in it. There'll be a surgical intensivist at there, but that person may have to work in consultation to the various ICUs that we've expanded to because of expertise that's needed at the bedside. Next page. Okay, let's talk about stuff. Next page. So let's talk about some good stuff for COVID and specifically for hypoxemia. I think what we've learned from COVID care, especially on the East Coast, is that high flow nasal cannula does have some opportunity within this patient population. In a recent meta-analysis looking at several papers in COVID-specific patients versus conventional oxygen therapy, high flow nasal cannula prevented those patients from progressing to more significant therapy. The issue, like all of this, is again, what is the risk to the providers and the patients in that floor with this type of approach? Specifically, what's the airborne risk? And so I think as we expand our needs and expand our footprint for critical care, high flow nasal cannula is going to have an important sort of influence in the care, but again, done in a safe sort of fashion. Next page. Like any of these patients, I think good stuff is early, elective, and controlled intubations. We're going to apply the open lung concept, which is being applied to lung injury ARDS for over 15 to 20 years now. What is that? Well, that's low tidal volume. We're going to optimize the PEEP on these patients. We're going to have a judicious exposure to crystalloid, and that we're going to apply prone therapy and possibly neuromuscular blockade, depending on the distinct of the patient. This is the gold standard of hypoxemic care, ARDS, and this is becoming very effective for our COVID patients. What about awake non-intubation proning? I think people have seen pictures of non-intubated patients in ICU environments or critical care environments being in a prone position. There is a signal for some of these patients that they may show benefit because of the VQ mismatch or changes thereof. But I think it's important to state that this is not an exclusion of early intubation. This is not a rescue therapy for somebody who really requires mechanical ventilation. If a patient needs to be ventilated mechanically, they should do so very early, again, in a safe and elective format. Next page. Well, what's bad for hypoxemia? I think we're beginning to learn that non-invasive mechanical ventilation is really not preferred. The older literature over the last 5 years has demonstrated that high flow nasal cannula, at least in our patient populations, is more beneficial than non-invasive. And I think the real unknown for non-invasive mechanical ventilation is really the large concern over the magnitude of aerosolization during this. So for a safety concern, and because the literature really favors high flow nasal cannula, we're going to focus on high flow over non-invasive, not only for the patient, but for the safety of our providers. Next page. All right, what's some other good stuff for our COVID patients? Well, first and foremost, Remdesivir seems to be the most helpful medication to date, at least for patients that are hospitalized, but not significantly that sick. So in that Act 1 trial, there was a double-blinded, placebo-controlled, randomized controlled trial of about 1,000 patients. And their primary outcome was time to recovery. So when did they get better? When could they leave the hospital? Or when could they could leave the hospital, but infection control said, no, not quite yet. And you can see that when Remdesivir was applied early to this patient population, they actually achieved 5 better days of recovery than those that did not receive this medication. Next page. When you look at the boxes, well, which patient population, that subpopulation within the hospital probably did best? And it's really those receiving oxygen. So again, a hospitalized COVID patient with moderate to mild hypoxemia, this is probably the patient population that should see Remdesivir early in the course of their therapy. If you look at the other populations, you can see specifically those that receiving high flow or non-invasive, there was really no separation of those two groups. Next page. What's another good medication? Pretty much in the, you can see the papers coming out in the lay press as well, is dexamethasone from the recovery trial. Really shows a benefit in severely sick COVID patients, those patients with severe hypoxemia. The difference between the recovery trial and the other trials is this is an open label trial and it's a multi-platform trial. So multiple medications, multiple interventions are being included in this large 15,000 patient population, really sponsored by the UK. And so at least in the recovery trial in this arm, they attempted to get 2,000 patients within the dexamethasone versus standard of care. Unlike the previous trial, the Act 1 trial, the recovery trial in all of its arms uses 28-day mortality. And with dexamethasone, for those patients receiving mechanical ventilation, there was improved survival. In those patients not on mechanical ventilation but receiving oxygen, there was improved survival. But what was really interesting in patients that weren't that sick, so they weren't receiving oxygen or mechanical ventilation, there was no real statistical difference between the groups. Next page. So when you look at the Kaplan-Meier curves, you can see at least in the right upper quadrant there that the invasive mechanical ventilation group, 1,000 patients were in that subpopulation, and there was a large split of these patient populations, and that was carried out to 28 days. So this is a really kind of a promising therapy, at least for our ICU patients. Next page. So what about the maybe stuff that we keep hearing about? Well, convalescent plasma is in the news. And what is this? This is plasma from recovered donors. And really what people are recommending at this phase, specifically the NIH is recommending at this phase, is that it should only be given to patients as part of a larger study. Right now at Harborview and within the University of Washington, that is called the Pass It On trial. And we're hoping to start this on Monday, another arm of the recovery trial, which is again, phase 3. What about monoclonal antibodies? We got a couple of weeks ago, this hit the press with Regeneron. Same thing falls into this category of these antibodies, that these antibodies should only be given as part of a study. They are not standard care in COVID patients. And this is yet another arm of the large recovery trial, and it's a phase 3 and it's an ongoing study. There are many drugs and sort of interventions that are currently being studied, not only with the recovery trial, but as sub-trials in the United States. And you can see that stem cells and azithromycin and interferons and protease inhibitors and vitamins, these are all being studied. But as of today, the real strength of evidence is in Remdesivir and dexamethasone. Next page. So what's bad? What's the bad stuff? Well, I think we all kind of know at this point that hydroxychloroquine has not been shown to improve the outcomes of our COVID patients. This was one of the very first arms within the recovery trial, and they attempted to include over 4,500 patients, and the trial was stopped early at 1,200 because at the interim analysis, it did not show any significant difference at the 28-day mortality mark. When you read through the actual paper, those patients that got exposed to hydroxychloroquine actually had more complications, dysrhythmias, et cetera. And so at this time, it is not recommended in our COVID patients. We, Harborview, University of Washington, participated in a hydroxychloroquine study within the PEDAL trial. And I'll just say that this trial was also closed early at its interim analysis. And this is going through the publication process right now. And I think one of the big bad stuffs of COVID care is really the misinformation that we're seeing throughout the lay press and throughout really what you turn the TV on or look at the internet. And I think it's really important for medical providers to really have at least a basic working knowledge of what's effective and what's not, because these questions keep coming up whether you're a surgeon or not. Next page. So where do you get the information? First and foremost, for those at the University of Washington, you go to the OneDrive. You go to the UW Medicine coronavirus page. It is an extensive web page of all of our protocols. I can tell you that the critical care community worked really hard to create this guideline for the management of the COVID patient. And we are constantly updating that guideline so that it can be available to anybody who wants to look at it. Again, the idea is that during surge capacity, we're going to have non-ICU providers in our ICUs, and we felt like it was very important to give the playbook to everyone participating in the care of these patients. And then finally, I would take people to the NIH COVID-19 treatment guidelines. I think this is a nice resource or one-stop shopping for looking at all of the studies that are coming out. Every week, there's more and more papers coming out. Some are important, some are not. And really, the NIH has this expert panel that reviews all the literature and then creates really strong grade level guideline recommendations so you can kind of sift through the noise. Next page. All right, so we talked about the space staff stuff, we talked about the good stuff, and we talked about the bad stuff for COVID care. Next page. Well, I just want to say thank you. It's a real honor to talk to everyone today. It's an honor to have Dr. Cornwell as part of our visiting lecturer. I look forward to his lecture this afternoon. And again, I appreciate the time. And if anybody has any questions, please send me an email at any time. I'm happy to help.
Thank you. Dr. Cornwell, again, welcome. And Dr. Robinson, I enjoyed your talk. I especially enjoyed the bad stuff. I am personally sad and shocked that IV bleach doesn't work. But we're going to switch a little bit. And as Dr. Kushgeri mentioned, this talk is going to be a combination of geriatrics with rib fracture. We have various bundles, and I'm going to talk about those two combined a little bit. And as it is, there are a lot of people that work on this topic. Specifically for this talk, Dr. Katie O'Connell, who is our assistant professor of surgery, and Dr. Paulson, who is our colleague in anesthesiology, have done a lot of this work under guidance of Dr. Robinson, Dr. Kushgeri, and Dr. Monica Vavilala and Dr. Balger. But I am here because Dr. O'Connell is on maternity leave, and I hope I can represent a lot of this data. Next slide, please. So we all know that geriatric trauma is getting more and more. Northwest UW North is one of our partners in trauma that their average age of trauma patients is now in upper 70s. Next slide, please. And the mortality rate in older adults is getting more and more, and compared to other adults. And that's not shocking. The older you are, the chance of bad outcomes is higher. The interesting part comes that I become everybody's favorite when I mention this. Older here in trauma is 55 and older, and this is getting younger and younger every year. Next slide, please. So as I discussed, we're going to combine two protocols that we have. One is GERI-T bundle or geriatric trauma bundle, and then rib fracture bundle. And when you combine it in older patients, it actually gives a strong platform for our hard review patients. Next slide, please. This is multidisciplinary. As I mentioned, there are lots of people that are involved in this, and there are multiple aspects on it. I am going to focus on the pain and sedation more than the other two, but the other two are just as important. Next slide, please. So frailty. When people talk about frailty, this definition is actually not that easy. Frailty is not comorbidities. It's not if you had diabetes or other things. And a lot of descriptions are there, but it is basically the ability to recover or ability to function. And I consider it sort of like, it's difficult to define, but it would be somewhat of a life force in somebody. And there are various methods. Dr. Bilal Joseph from Arizona has had multiple new ways and 50 questionnaires that really works for trauma. But this one we chose because it's simple, it's pictorial, people can choose, and you can choose whether you're one, very fit, and these days I don't know where I am. I think I'm somewhere around 3, but it's a good way to look at the frailty, and frailty is very important in outcomes. Next, please. We at Harborview, when we look at our TQIP Trauma Quality Improvement Project data, it becomes very clear immediately that we are an elite group in trauma centers in the country based on that data. And this sounds arrogant, but I'm just following what the data says. As far as mortality for blunt and penetrating trauma, we are significantly better than what our predicted ratio of mortality is going to be, and consistently in the top performers. But when we looked at it, and Dr. Balger and the group looked at the TQIP data, when it comes to older patients, while our mortality is still the top performer, there are certain group of patients that our complications could improve, and we are not in the top performers. And that question was in respiratory group. Our group, including Harborview Injury Prevention Research Center and Rob Tessler, who was one of the previous T32 fellows here, looked into this, and we looked at the group of patients that were not supposed to have complication based on their frailty and everything else, and they did. And then it turned out that one of the things that made a difference was if we had geriatric consult in them or not. This is already published in Journal of Trauma, but based on that, we have developed this model of based on your frailty, as soon as the patient gets admitted, you are categorized in various groups. And if you are high frailty, you have medicine G, which is our geriatric team consult here, plus palliative care, because palliative care is quite big in our hospital as far as being able to discuss goals of care with the patient and immediately have an understanding of where is it that we are going and is this where the patient wants to go. And based on these, we'll get medicine G consult or medicine G and palliative care consult based on the age and the comorbidities and frailty score. Next slide, please. We also do a nutritional assessment. I'll talk about this a little bit more later. Next slide, please. So rib fractures. Rib fractures are one of the biggest portions of trauma, not only for geriatrics, but any blunt trauma. And studies done in our institution under Dr. Balger was actually probably one of the few randomized clinical trials, looked at rib fractures and use of regional anesthesia, which I'll talk about a little bit later, but also looking at rib fractures and the effect on outcomes, mortality and other outcomes, especially when it comes to older people. We realized that based on these, that there is a hole in management of rib fractures. When we look at how we designed our trauma system, it was designed for really sick patients, for instance, after a motor vehicle crash and being young male. But the universe is changing. Older patients are taking over as far as trauma, and now fall is the #1 cause of trauma instead of motor vehicle crashes. And rib fractures and how we manage it becomes really important. Based on this, we created our rib fracture protocol, and this is the list of the inclusion criteria. Next. Part of this is what the PIC score, or pain, inspiration, and cough score. Based on this, based on the level of pain that the patient has, we give them a set of scores. Inspiration is based on how they do with incentive spirometry and how much volume they can get, and the cough, the ability to cough. And the higher scores are better. And we use that score, especially for older people, to decide where they need to go. Especially with 3 or more rib fractures in older patients, we admit them to our intensive care unit for aggressive respiratory management. Next slide, please. The nutritional assessment is big in this part. Dr. O'Keefe is focusing on nutrition, especially in the ICU, and he has an R01 now looking at this aspect. And this is part of the geriatric bundle in addition. Next slide, please. So the pain management becomes a really crucial part of rib fracture management, and they come in hand. We realized really early that delirium is also a huge part of this. And the medication we use is in part responsible. And I'm saying in part because there are it's multifaceted, responsible for the delirium that we have in our patients. Therefore, the focus was on non-opioid management, Tylenol, and again, non-steroidal anti-inflammatory medication, In the group of geriatrics, we have modified this based on this protocol, and there is not enough time to go into it because there are concerns for acute kidney injury in this group of older patients, and we have modified those. But we go heavy on these for our geriatric population as opposed to opioids. And in case of opioids, we have decreased the dose because we have noticed significant effect on our older patients, especially some of our high frailty older women with fall, and they have changed the doses for oxycodone in this group of patients. Sedation is a big issue. This is an issue that is actually, as people know, it's something that I have focused on. Use of sedative medication, especially in older patients and in general in all patients, is associated with significant risk of delirium and bad outcomes. In this group, when it gets to benzodiazepines, they are like a level of their own, and we will avoid benzodiazepines in this group of patients as much as possible. The universe in sedation has changed. The Society of Critical Care Medicine now says, first, manage pain, then consider sedation. The idea that every patient that is intubated requires a sedative is also changing. And now there are papers initially papers came out decreasing sedation, then papers came out, give sedation a break, and that improves outcome. Now papers are coming out that no sedation, a management of ventilator patient. And I think the risk of delirium in this group of patients based on studies is significantly decreasing. Based on the PIC score that we already discussed, we also get our acute pain relief service involved and regional anesthesia. Regional anesthesia in our hospital is big. Again, as we discussed, Dr. Balger did the initial randomized study, which is considered to be one of the top 20 papers now. And then we as the group, Dr. Kushgeri and our previous fellow, Dr. Gage, looked at epidurals and their outcome and demonstrated when we use the national databases that the epidurals is still the best way to go to decrease mortality and risk. But interestingly, while trauma centers use more epidural, there's still only less than 5% of the people who qualify. And these are people who actually, based on data, qualify to get the epidural. Our hospital is not an exception, although we are the leaders showing how beneficial it is still not used as much, and we have issues to overcome. Recent studies by Dr. O'Connell demonstrated that use of epidurals was associated with significant risk of delirium, and this was in a multi-center study with Dr. Robinson and the East group that was done on 7 different hospitals. Next slide, please. Next, please. So what we have worked all of this, and with a big group, and we have focused on it. And the group, as I discussed, is a big group of the providers, all of the trauma critical care members. And did we get a result? Because we focused on it to decrease our ICU readmission, which was one of the complications, is decreasing, although we use ICU quite a lot more than other centers. Next slide, please. There is decreased risk of complications and delirium, and Dr. O'Connell is working on, the team is working on it, and to provide the paper for the future publications. But this is ongoing work. We have a geriatric committee here with May Reed, and multi-center group is part of this, which is our geriatric team. And we are looking at various focuses. Current focus is use of second-generation antipsychotics like Seroquel, because we are comparing ourselves to others, and we are using a little bit more Seroquel, but the recent data regarding use of Seroquel and delirium are coming out that it does not improve delirium. And in fact, some studies have shown that it may increase it. So again, we are using a lot of these medication, and trazodone is now becoming a little bit more favorite, but we are continuously quality assuring the system. Next slide, please. Next slide. So ICU admission and appropriate pain management comes hand in hand. We initially decided that we want to get the ICU admission of all geriatric patients because we were focusing on respiratory toilet. And our thought was they come to ICU, they get more focused care, they get more respiratory toilet. The problem is, as we discussed with various groups, and as I've discussed with Dr. Robinson, Dr. Kushgeri in the past, and Dr. Bulger, is that our ICU was designed for really sick patients. And we started bringing these patients in without, providing education and the basic background as what do we want these older patients in ICU to have. So I think this idea of whether ICU admission will help these patients or not is still debatable. Next slide, please. Again, thank you very much. This is a multi-team and there are many people involved in it. And it was a pleasure to be here and talking about this with you. Thanks again.
Good morning, everyone. Thanks for the opportunity to present, and welcome again to Dr. Cornwall. As Dr. Kushgeri mentioned, one of my research interests is really focusing on post-discharge patient-centered outcomes for injured patients, and that's what I'm going to focus on today. Next slide. I have no relevant disclosures. The goals are going to be twofold. I hope that by the end of the talk, you have a better understanding of sort of the functional and the psychosocial impact of injury, and an appreciation for those individuals who are at highest risk for adverse outcomes after discharge, so that we can sort of target those individuals with regards to future efforts to improve those outcomes. Next slide. So injury and violence is a huge problem in the United States and globally. If you look just at the US alone, over 200,000 people die every year as a result of injury and violence. And for every person that dies, 13 are hospitalized and over 130 are treated in emergency departments. The economic impact is real also, almost $700 billion in medical and work loss costs annually in the United States alone. And if you just think about the fact that more than 90% of injuries actually occur in low and middle income countries, the global impact of injury in this regard is really, I think, not well understood, but huge. Next slide. So we're actually pretty good at taking care of injured patients with in-hospital mortality in the United States at less than 4%. And not to say that there aren't further advances and improvements to be made there, but I think this finally allows us to really focus on what happens after discharge and sort of that post-discharge experience. Next slide. So I think part of the issue is that when people think about injured patients, they oftentimes think of young, healthy individuals who are just going to bounce back and get back to their lives. But unfortunately, as we're studying this, what we're realizing is that that is far from the reality that a lot of these patients face. They oftentimes struggle with regards to poor functional outcomes, social disintegration, not being able to get back to their roles within society in the way that they would like. And also they struggle a fair bit from a mental health standpoint, and I hope to touch on each of those. So some of the, there's a lot of different things you could look at with regards to endpoints and outcome metrics post-discharge. Some of the ones that I'll touch on are listed here. I won't really get into the financial impact because I think that's a whole separate talk, but we'll touch on each of the others. Next. Talking first about functional outcomes. So our group and some other groups that have studied this have found that, functional outcomes after moderate to severe injury really aren't great. So even if you look at patients 6 to 12 months after injury, almost 40% of them reports newly needing help with an activity of daily living since their injury, even 6 and 12 months out after their injury. And 50 to 60% of individuals report that they have problems doing their daily activities and getting through the things that they want to be able to, again, even 6 and 12 months out. And there's sort of a plateau after 12 months. And this has been seen when we try to study outcomes past that point, where even if you look at 24 months after injury, so 2 years later, only 23% of patients report that they have good functional recovery. That means that 3/4 of our patients overall are sort of unsatisfied with their functional recovery. And I think this sort of, next slide. The other side of this is that, we see acute pain a lot after injury and we deal with that, but chronic pain is a real problem after injury. such that even like 6 to 12 months after injury, half of our patients are telling us that they have chronic daily pain. And almost all of those report that that pain really does limit their ability to do the things that they want to do. And a quarter of the patients overall are still taking pain medications, newly taking pain medications since their injury. And we don't really know what those pain medications are. We don't have granular data on that. And not to say that they're all narcotics, but they're still taking pain medications of some sort for their injury-related pain. Next slide. And I think it's not surprising if you take the functional limitations and the chronic pain sort of into consideration that getting back to work is a problem for a lot of these individuals. So if you look at just the subset of individuals who were working prior to their injury, so you're not talking about people that are older and retired or who weren't working for whatever reason, but just the ones who were working, at 12 months after their injury, only about overall about 40% had not yet been able to get back to work. And again, you see this plateau where if you look out at 24 months, 30% still had not been able to get back to work. And obviously this has implications for their families, for their finances, and for their mental health overall. And that segues to the next slide, where I want to talk a little bit about mental health, because I think this is a huge part of the recovery after injury. And I think that the mental health consequences of injury are really intricately related to the functional recovery. And it's hard to tease them apart, and I think they go hand in hand. And if we're going to start sort of addressing this and trying to improve this, we really need to address both. So from a mental health standpoint, if you screen patients for common mental health conditions like PTSD, depression, and anxiety after moderate to severe injury, 1 in 5 individuals screens positive for moderate to severe PTSD, depression, or anxiety. I'm not talking about like mild anxiety, which probably almost every person has. I'm talking about moderate to severe symptoms. And the mental health condition that we think of most commonly after injury is PTSD, right? So about 1/3 of those patients will screen positive for PTSD. But when we looked at depression and anxiety, we found that a significant portion screened positive for both of those. So 78% for moderate to severe depression and 74% for moderate to severe anxiety. And as you can see from this Venn diagram that's at least close to scale, is the fact that there is a ton of overlap. So there's actually very few patients that have one isolated mental health disorder after injury. These conditions oftentimes coexist. Next slide. And if you start looking at the relationship between mental health disorders after injury and functional outcomes, what we found is that not only does having a mental health disorder after injury impact or seem to be correlated with your functional recovery, but there's a cumulative burden effect such that the more mental health disorders that you are struggling with, the worse your functional outcomes seem to be. So here you can see chronic pain, a limitation in an activity of daily living, and your SF-12 physical composite score as a general marker of sort of physical well-being. This first column is no mental health disorder, and then you have 1, 2, or 3. So those individuals that screen positive for PTSD, depression, and anxiety, which again is not an uncommon situation because we see a ton of overlap, were 10-fold more likely to struggle with chronic pain, 8-fold more likely to struggle with an activity of daily living newly since their injury. And they had significantly lower SF-12 scores from a physical standpoint 6 months after their injury. Next slide. So I think suffice it to say that after a lot of our patients after moderate to severe injury are really struggling from both a functional and a mental health standpoint. I think the next logical question is, what are some of the risk factors for adverse outcomes? And there's a few risk factors that come out sort of over and over again. And certainly the risk factors differ based upon the outcome metric that you're talking about. They're going to be different based on what you're talking about. But some of those sort of consistent risk factors are low socioeconomic status, having a low resilience. So resilience is sort of your ability to deal with an acute life stressor or an unexpected life event. So having poor coping skills and low resilience is certainly associated with worse outcomes. Having a poor social support network to depend on. And then although injury severity over and over again does not seem to be correlated with our long-term outcome metrics, the mechanism of the injury certainly is, and particularly from a mental health standpoint. So individuals who are injured as a result of an intentional mechanism tend to struggle more from a mental health standpoint. And I think these risk factors are important to take into consideration if you're going to talk about interventions to try to improve these outcomes. And I would actually argue that although it's not easy, a lot of these risk factors, or sort of what seem to be factors correlated with poor outcomes, are actually modifiable. Again, probably not easy to modify, but modifiable. So socioeconomic status could be modified by providing housing, jobs, education. Resilience is something that can be taught with adequate sort of mental health support services. And social support networks can be created post-injury. So that's sort of the next phase of this work. Next slide. You can move forward, yeah, thanks. That's sort of the next phase of this work, is trying to identify those individuals at the time of hospital discharge that are at highest risk for adverse outcomes, and then trying to do things to modify some of those risk factors for those adverse outcomes. Next slide. So in conclusion, I would say that many of our patients struggle from both a functional and a psychosocial standpoint after injury. And as we sort of understand this and the risk factors associated with adverse outcomes, we really want to work towards moving towards strategies to improve those outcomes while systematically studying those interventions to see if they're effective. Thank you.
Good morning, and thanks for the opportunity to talk to you. I'm going to talk about a couple of advances in burn care. Go ahead to the next slide. I am going to talk about a couple of products in here. I do not have any financial relationships to either one of them. So this is the current state of burn care since about the 1980s. The standard of care has been excision and grafting for full thickness burn injuries. And that leaves us in a little bit of a challenged state when we talk about partial thickness injuries, or injuries we're not sure are completely through the skin or aren't going to heal. Next slide. In addition, we often have to stretch skin out over larger areas to expand donors. We do that by meshing skin grafts. And this in particular here, you can see on the lower abdomen, a fresh 4:1 skin graft. And on the upper chest, you'll see a 4:1 skin graft that's actually been in place for about 8 days. And so the healing time on those is really rather slow and can result in long periods of wound care. Additionally, when we're unsure about the nature of the wound or whether it needs to be excised and grafted, we have patients who wait for sometimes 7, 10, or even 14 days before surgery, all that time getting rather difficult wound care. Next slide. And then in addition, we have the challenge of donor sites. So donor sites are not free. When we take large donor sites, those areas will in and of themselves scar, and those scars can be problematic. And that scarring can, in fact, persist for years, causing problems with pain, itching, range of motion, and other functional issues. Next slide. So all that brings us to what to do with somebody who has a hand like this. Very sensitive area. It looks like a deep burn, but it's on the palm. We're really kind of unsure. Maybe it's got some healing potential. In the past, what we would do is we would leave this for maybe 7 days, 10 days, 2 weeks, maybe even 3 weeks to avoid trying to graft on the palm if we were unsure about the depth of injury. But now we can potentially accelerate that process quite a bit with a new medication. Next slide, please, which is called Nexibrid. So Nexibrid is the reason why pineapple gives you heartburn, if you've ever wondered that. So this is basically a distillation of the bromelains in pineapple extract. And what it does is it acts as an enzymatic debridement. And you can place it on a partial or even full thickness burn, and it will, in fact, debride the dead protein and dead skin away. Of course, this is not a get out of jail free card. So number one, this hurts. So it requires a significant amount of pain medication and anesthesia support in terms of regional analgesia or general analgesia. And it causes an inflammatory response, much like the burn. So once you get a wound that's up about 20% of the body surface area, you have to be very careful. And we've had experience with even lower percentages where we've seen a SIRS response after applying this product. But what it does, next slide please, is it allows us to take that hand and in a matter of hours, get an answer for how deep that burn really is. And as you can see here, there's that same hand. There's some dermis there, but if you'll notice on the thumb, the lower thenar eminence, you're looking at veins that are thrombosed, you're looking at exposed fat. We know that this needs to be grafted. Next slide. And now instead of waiting 2 weeks, here's that patient 2 days later with their skin graft in place, already beginning the healing process. And we've essentially accelerated this patient's care and potentially shortened their hospital stay by a matter of 7 days or even up to 2 weeks. Next slide. But as I've said, this is challenging with larger burn wounds. And when we're doing a sheet graft on the hand, we're still using a significant amount of donor skin to get that coverage area. So what about these larger deep partial thickness burns where we're sort of like, I don't know, is it going to heal? Does it need to be excised and grafted? If there's living dermis there, can we use it? Well, the answer is, yeah, now we can. Next slide, please. This is a product called RECELL, which some of you may have heard of as spray-on skin. And what this is going to allow us to do is basically take a donor site, suspend the cells, and spray them back onto the wound. Next slide. So the advantage of this is we take a small piece of donor skin, we put it in heated trypsin, and then basically mechanically scrape all of the epidermal cells off the dermis and put it into solution. So that includes the keratinocytes, but also the melanocytes and the immune cells like Langerhans cells. They're suspended in a solution, and then we can actually spray them back onto the wound. So now instead of using a large donor area to cover a big wound or using necessarily all 4-to-1 mesh graft, we can use basically a small 3x2 centimeter skin cell, and each one of these trays will process 4 of those. And that gives us up to 2,000 square centimeters of coverage. So in other words, that's almost an 80-to-1 expansion, which is much greater than the 4-to-1 expansion that we are used to. Additionally, we have the advantage of taking a much thinner donor site. Our donor sites are usually taken at about 11 thousandths of an inch. The donor sites for RECELL, we just want the epidermal cells. So we're basically taking those donor sites at 0.006 or 6 thousandths of an inch. That's nearly half the thickness of the donor site that we need to use to get coverage here. Next slide. And so instead of excising that entire arm, where we have about 2,000 square centimeters, we can basically dermabrate it. We can basically shave off the debris and a little bit of the remaining tissue down to nice healthy dermis, and we spray these suspended cells back on. Next slide, please. So here's that same patient preoperatively after we dermabrate it, and 1 week later after spraying these cells back on, and you can see that his left arm is actually completely healed after applying these spray-on grafts. And in addition to that, the donor site that we use to cover that entire arm, right, is only 4 2x3 centimeter patches of skin. So that's 1 24 square centimeter area. And to give you an idea of how big that is smaller than a standard deck of cards to cover his entire left arm. Next slide. But we can also use this to apply to other areas. So remember that challenge we had when we take mesh grafts and we spread them out to 3 or 4-to-1 to get that expansion. Those take weeks to heal in. But here's an example of a 3-to-1 mesh graft. This is actually a recent patient that we had where we've taken the 3-to-1 skin, we've applied it to the excised wound bed and then sprayed RECELL over it. And 1 week later, that mesh graft is entirely healed. And we've taken the patient from a large open wound to closed. And that's not all we can do with this technology. It has the potential even to be sprayed back on for a smaller piece, to be sprayed back on to donor sites for these larger excisions and heal donor sites even faster. And we don't quite yet know exactly what this means for scarring, but that's one of the reasons why we are going to be starting some ongoing clinical trials to see what some of the other long-term impacts of using technology like this is. Next slide. So really what we've done here is potentially changed our paradigm with 2 new tools in the toolbox, gone from necessarily just having excision and grafting to now either enzymatic debridement for a faster surgery decision, or imagine if we had enzymatic debridement down to nice healthy dermis, we could go straight to RECELL. and simply recover that entire area with a sprayed-on suspension of cells, keeping the donor sites to very minimal areas, or in some cases to areas where we could actually take the donors and sew them closed and remove the donor site healing entirely. And so this epithelial suspension combined with RECELL is going to allow us some faster decisions to surgery, smaller donors. We can cover mesh grafts with epidermal cell or epithelial cells that will help heal them in faster, and get much more rapid wound closure. Next slide. And with that, I'm happy to take any questions in the panel.
Thank you. Again, excellent presentations. We have a few minutes for some questions. Dr. Wright asked a question regarding postoperative and post-discharge management of patients in terms of their opioid requirements to Dr. Nira, but I actually like to extend it to the entire group too as well in terms of management for rib fractures in the geriatric patient population, post-discharge trauma patients, as well as burn patients. I know each of you have intense interest in the management of these patients, but how do we manage their postoperative pain, multimodal therapy, other avenues in terms of pain management, including with physical therapy and other avenues? Thoughts about that in terms of trying to reduce opioid use?
I can just start with regards to a comment on pain control and sort of long-term outcomes. It's a little bit of a double-edged sword because we know that better pain control after discharge seems to be associated with better long-term outcome metrics. But how we obtain that pain control, I think, is something that we're still trying to figure out. There is a lot of variability with regards to how and what we're using to obtain pain control for our patients. We recently looked at this and we found that at least at the time of discharge, there was a 90% variability with regards to what pain control was provided and sort of what regimen was used that we couldn't explain by clinical factors or injury-related factors and things like that. So it seems to be a lot of variance out there in terms of how we're doing this. In terms of like an organized approach to this, I think that there's a general interest in using multimodal analgesia and trying to not use narcotics, which are not necessarily superior in terms of pain control. There's at least one RCT trying to look at that sort of approach to trauma patients that I know of that's being coordinated out of Texas, trying to use sort of an opioid minimizing multimodal approach to pain control in trauma patients and looking at sort of outcome metrics. I'll pass it off to others there.
Thank you, Dr. Kouchgeri. And Dr. Wright, that's a great question. As you know, we currently have a CDC-funded research that we are doing at Harborview, looking at patients that are discharged from Harborview and following their opioids. And we have a physician assistant that actually contacts their primary care physician and is working with them in a randomized clinical trial to decrease the amount of opioid use in trauma patients after discharge. And it becomes very clear that there are two groups of people, opioid naive and opioid patients that were on opioid before their injury. And that group is actually not small, the group that were on some kind of opioid before their injury. And those two are functioning very differently in the groups. And we'll wait to see how this works in our CDC grant. Also, a group of Harborview Injury Prevention and Research Center team are working on looking at patients by following them before their injury using our CHARS data and our prescription pain medication data to know how much they were taking before their injury, and then follow them 1 year after their injury. Because as Dr. Nehra mentioned, it becomes very clear that the thing that is more important to them is not how much injury or the injury severity score. Actually, the issues are psychiatric issues that the patients had, or how much opioids they've used. And these are not new. Dr. Davidson, when she was a fellow, looked at this with a group and showed that when you have psychiatric issues before injury, actually affects the amount of pain medication or issues that you have afterwards significantly. So as discussed, this is a multimodal issue, and Harborview is in the middle of it with multiple research projects that are ongoing.
guess I'll ask an additional follow-up to Dr. Robinson, who presented some great data around COVID. What were lessons learned in terms of the management, especially the cohorting of COVID-19 patients in the ICU? Did you see issues with that cohorting?
That's a great question, Joe. I think when we first started the process, we really want to focus on cohorting because of safety issues with donning and doffing, familiarity with coming in and out of the room, and really the care paradigm surrounding those patients. And as we quickly realized, there are patients where their trauma needs or their surgical needs far outweigh the medical issues of COVID care. And so at that point, we really had to pivot and find negative pressure capability, training our TSICU nurses to really become familiar with COVID care and their trauma care. And I think as this evolves, we're all going to have patients that have COVID plus transplant or COVID plus a thoracic disease or COVID plus trauma. And I think we're really going to have to work with our medical intensivists, but also to really continue to have ownership of these patients. Otherwise, their surgical or their trauma issues are going to be minimized, which is not in their best interest.
Thank you. And another question that's brought up by Dr. So to Dr. Mandel specifically in regards to use and application of RECELL to other types of wounds, those from necrotizing infections or large abdominal wounds. How do you see this playing a role or potential role in the future?
Yeah, so I think RECELL can be applied to many of those areas potentially in conjunction with skin grafts. So you do want to remember that we still need the dermis there, and so that's why it works when sprayed over a meshed graft. You can't just spray it directly onto the excised wound bed. The challenge with things like necrotizing soft tissue infection, if you're not re-excising it, is you often have biofilm or lots of bacterial colonization in the wound. And what we're finding, at least early on, is that the cells, when you spray them on that wound that's been chronically open, have a lot harder time competing for growth. So I think how flexible we can be with that is going to be borne out by some of the longer term studies we're doing. And then Dr. Flum had a question about whether or not this was going to be widely available. And the answer is, it is pretty widely available. There are currently, you can use it in most burn centers. Epithelial cells grown on gauze have been around for a very, very long time, but they also don't have dermis and are cost prohibitive. These kits have the cost down to about $6,000 a kit, which is high, but it is relatively manageable, and so they're much more widely used.
Well, I'd like to thank all the presenters. This was absolutely incredible. This is great work by all of you. Really been humbled to have worked with you all these years too as well. So thank you for the opportunity to help allow me to moderate this session. And at this point, I think we're going to take our first break.
All right, well, welcome back, everyone. So this second session, we're going to spotlight some efforts in the department from members of the Diversity Council on social justice and diversity efforts in the Department of Surgery, as well as featuring our Harkins lecture from Dr. Cornwell. First, we'll start off with Dr. Andre Dick. He's the Surgical Director of Pediatric Kidney Transplant at Seattle Children's and the Transplant Fellowship Director at UWMC, and he'll give an overview of the diversity in academic surgery. Next, we'll have Beth Ann Riemel, who is a trauma and general surgeon at Harborview and has played a lead role in managing the Diversity Council survey for the department. And she'll give some preliminary data from that and some efforts that will be forthwith. Next, Dr. Andy Wright, who's the Minimally Invasive Surgery Fellowship Director at UWMC and Director of the Hernia Center at Northwest and the Center of Video Endoscopic Endowed Professor at the Department of Surgery, along with Gianna Davidson, who's the Chief of Staff elect at UWMC and the Section Chief of Emergency General Surgery at the University of Washington, as well as the PI of several randomized national trials that have will soon have impacted national standards of care. Together, they're going to describe some of the anti-racist initiatives that are ongoing and emerging in the Department of Surgery and the Division of General Surgery. And then we'll have a talk featuring Estelle Williams, She's a UW general surgeon and the executive director for the Doctor for a Day outreach program in the School of Medicine. And Edwin Lindo, who is a critical race theory scholar in the Department of Family Medicine and the Associate Director for Equity and Critical Teaching in the Center of Leadership and Innovation in Medical Education. And to wrap things up, we're going to feature the Harkins lecture by Dr. Eddie Cornwell III. He's one of our nation's top surgeons, the Surgeon Chief at Howard. I'm not going to, we're going to get a large introduction afterwards, but I will encourage everyone to go on to Amazon Prime. There's a documentary called The Transcending Surgeon, which really gives an amazing description and story of his life and insights into his life story, which I'd encourage everyone to take a look at. But without further delay, we're going to go right into it. And Andre, why don't you go ahead and start?
All right, next slide. Good morning, everyone. I'd like to thank Dr. Wood, Dr. Wu, and the Harkins Society for allowing me to present today. And again, I'd like to establish a warm welcome to Dr. Cornwell and looking forward to his speech. So I was tasked to give like a sort of a brief overview of diversity in academic medicine. Next slide. I have nothing to disclose. Next slide. So we're currently undergoing unprecedented times with the COVID pandemic and also the pandemic of racism. And it is unfortunately that George Floyd, Eric Gardner, Breonna Taylor, Philando Castile, Ahmaud Arbery, and Trayvon Martin, amongst many others, have unfortunately suffered untimely deaths secondary to institutional and structural racism. You know, these recent events have led to an outcry from every major academic institution across the country, and they have crafted well-released statements that our society have never allowed for an even playing field, which has not only led to disparities but also inequities in care. Next slide. So this is the most recent census data from the U.S. population, and as you can see, underrepresented minorities represent about a third of the U.S. population. And the definition of underrepresented minority by the census data are people or citizens who are both naturalized or permanent residents that have African, Latinx, Native American, Pacific Islander, and American Indian heritage. Next slide. So despite representing about a third of the population in academic medicine, they represent about 10% of the people of the physician workforce. And you know, it's definitely been shown that increasing diversity in the physician workforce is a key step towards eliminating healthcare disparities in the United States. It's also been well documented that underrepresented minorities are the folks who are going to be taking care of people in underserved population. Next slide. When you look specifically at general surgery residents, they also represent a very small proportion of the workforce, and this is based on the 2016 AMC data. And interestingly, there's been very small or no changes in this number since the 1960s. When you look at the faculty positions for Black or African American surgeons, there are fewer Black assistant, associate, or full professors within the Department of Surgery across the United States. If you exclude the historically Black colleges and universities, there are only 4 Black chairs, which represents only 2.6% of all the chairs, of the surgical chairs in the United States. This number is even more abysmal if you're a Black woman. There's actually never been any Black woman that's a chair of the surgical department. Next slide. This is one of the things that's pretty striking, that even over the last 2 decades, as the U.S. population has been increasing, as well as the number of medical school spots been increasing, the number of underrepresented minorities going to medical school has actually decreased. We're actually heading in the wrong direction. Next slide. And the one group that's been particularly hit the most are Black males. There are actually less Black males applying to, matriculating, and graduating from medical school today than in the 1970s. Next slide. This basically shows that, again, the numbers have not significantly changed over the years. Next slide. So people talk about this kindergarten to medical school pipeline as one of the potential reasons as to why there's, not a lot of diversity within the workforce. And as you can see, this pipeline, is leaky from sort of middle school to high school. And then when you get to college, it even drops off even more. So by the time you get to medical school applications, there's almost no one or a very, very small pool to apply from. And one of the sort of thoughts around this leaky pipeline, it's multifactorial. It's, socioeconomic status, lack of role models, mentorship, infrastructure, and a lot of it also has to do with poverty. 20% of Latinx or African Americans live in poverty. Poverty leads to poor education, not good educational systems, poor health, and it becomes a vicious cycle. And this is actually a huge problem for not just underrepresented minority, but society as a whole. Next slide. So we've often been told that through hard work and determination, you can succeed and you can transcend any barrier that's placed ahead of you. And actually, this is not true, as you can see in the previous slides that I've placed. That there's been no measurable improvements in diversity or inclusion in academic medicine or surgery made despite excellence. Dr. Paris Butler is one of the plastic surgeons at the University of Pennsylvania who published quite a bit on this topic, and he says that there's actually real actionable items that can change the course that we're currently on. And he basically says it starts from the top, meaning surgical chairs, deans, leaders in the hospital can use their platform and privilege to help improve these diversity efforts. Unfortunately, underrepresented minorities in academic medicine or surgery cannot fix these problems by themselves, no matter how intelligent, technically gifted, talented, motivated, or well-trained they are. A lot of this change needs to come from the group as a whole. Some of the things that we're doing here in the Department of Surgery, and it's led by Dr. Wood's leadership, is, we have this diversity internship where we try to recruit underrepresented minorities to come and spend some time here in the Department of Surgery as they're applying for residencies. There's a Society of Black Academic Surgery Scholarship that sponsors residents and junior faculty to attend the meetings, to meet with some of the great leaders in academic surgery, such as Dr. Cornell himself, who is always here at the meetings to provide advice, mentorship, and sponsorship for us. Next slide. So one of the other ways of sort of changing the course on this is appropriate mentorship. And mentorship, it's been well documented that with if it's appropriate, there's significant benefits for retention, talent development, and job performance and advancement in leadership within any field. And that's also true for surgery. And as I said, again, Dr. Wood's strong leadership here, we're in the process of developing an early faculty mentorship program that Gianna may mention a little bit about. She and Dr. Oschlager is leading those efforts. And, again, mentorship is critical. You need a good mentor to help motivate you, give you advice, and provide support and coaching. But more importantly, next slide, I think, is sponsorship. Sponsorship, as this cartoon sort of depict a mentor ask you, do you want to apply or to give a talk, while a sponsor recommends you, say, hey, I already recommend you to give this talk, can you do it? And so, it's a big deal to have good sponsorship. A sponsor believes in your value and your potential and is prepared to link to your reputation and go on a limb on your behalf. They essentially provide air cover for you and give you opportunities to go out and fail. And they also give you access to resources that you may not have. Again, like I said, despite how motivated, hardworking, and talented you are. Next slide. So this is just a slide that shows you the difference between mentors and sponsors. Sponsors are proteges. They're the ones that are sitting at the table when big decisions are being made. They help to drive your career vision. They're personally vested in your upward movement, and they give you visibility. They give you all these opportunities and exposure. Next slide. So this is a slide that talks about a model for leadership and advancement. And this slide I got from Dr. Henry Ford, who's the dean of at the University of Miami School of Medicine. And he basically says that if you want to move forward from a surgical leader to become an emergent leader and a surgical leader, there are basic steps that you have to take. You have to have improved access, outstanding role models and sponsors. Again, you also have to be excellent in what you do. You also have to be in a nurturing environment that provides appropriate sponsorship for you to become a leader. Unfortunately, for underrepresented minorities, one, there's poor pipeline. Next slide. There's few role models. There's inadequate support, lack of appropriate mentorship, and even if you survive the pipeline, you get by the inadequate support or role models, and you become an emergent leader, you still have more barriers that you have to overcome to become a surgical leader. Again, there's few sponsors, lack of access, and limited scholarship and lack of infrastructure. So there's many barriers along the way that one has to overcome. Next slide. So yeah, this slide, it's the next two slides are conclusion, but there's a red line that's going through it. This work is never done, so it's not necessarily a conclusion. The work around diversity, equity, and inclusion, it's a lifelong process, and it's definitely documented that the lack of it, as well as racism, comes at a tremendous cost to everyone, not just patients, but to society as well. And people often talk about diversity, equity, and inclusion, and I think diversity alone is not enough. Diversity is who's in the room, but inclusion is who has influence in that room. And I think the inclusion piece is the part that sort of the cornerstone of all this work. And this was the statement from the University of Washington Department website, and it says the department will provide compassionate and high quality patient care, train future generations of surgical leaders, and conduct research in a collegial environment which embraces diversity and promotes inclusiveness. Now, clearly there's no way you can live to these values or accomplish these goals unless you're in an environment of diversity and inclusion. And again, I just want to reiterate that we've been fortunate with Dr. Wood's leadership and Dr. Pellegrini's sort of legacy of leveraging their status to move this forward. I earlier talked about the leaky pipeline, another way of trying to course correct. And this is some work that Dr. Estelle Williams have been doing from the Department of Surgery. Is Dr. Day, where they expose kids K through 12 from underrepresented backgrounds to healthcare careers. And I think Estelle maybe touched a little bit on this in her talk. Next slide. So again, critical to increasing the diversity and as well as inclusion in academic medicine and surgery is mentorship and sponsorship. There's things that departments have been working on, and I think Gianna is going to mention some of these. We're currently working on the cultural monthly M&M within the Department of Surgery. We have our annual diversity grand rounds. We have implicit bias training grand rounds coming up to help with the interview seasons. And all these things that are being done here in the Department of Surgery could be a potential model that could be used across other surgical departments in the country. And I'm very fortunate to be working here with solid surgical leaders who are kind of at the forefront of pushing diversity, equity, and inclusion. And that's the end of my talk. And I'd like to thank everyone so far. I'd also like to thank the speakers from the Trauma Critical Care Group, all excellent presentations, and to congratulate Dr. Arbabi on his successful recruitment of a very diverse class, the incoming class of the Critical Care Fellows. Thank you.
Hi, good morning. I'm Beth Ann Reimel, and I'm speaking on behalf of the Department of Surgery Diversity Council this morning. We'd like to share some of the results of the Diversity, Equity, and Inclusion Survey that was sent to all members of the department at the end of May. Next slide. So diving right in, I believe that racism exists in society. The large majority of department members either agreed or strongly agreed that racism does exist in society. Next slide. But it is important to note that there are a few department members who are neutral on this statement or disagree with this statement. Next slide. Question 2, I believe racism exists within the Department of Surgery. So you can see here that the responses were much more varied. The majority of folks did think that racism existed within the Department of Surgery, about a third of us. But the next most common response, about a quarter of us, 25%, was neutral, neither agreeing or disagreeing. Next slide. You can see that coming in right under that, people who did not believe that racism existed in the Department of Surgery, about 13%, and 13% as well strongly felt that racism existed here. Next slide. So looking at these two side by side brought up some interesting discussions in the council because they are such a contrast. And also brought up how people look at racism and how the different forms of racism can be defined. So we thought we'd add those here. Next slide. So there's individual racism, so the prejudgment stereotypes about an individual or group based on race by an individual. And the impacts of racism on individuals also include both people of color internalizing oppression and white people internalizing privilege. Then there's institutional racism, so the programs, procedures, policies that tend to work better for white people than for people of color. And usually this is unintentional or inadvertent, but still happening. And then structural racism. So the interplay of the programs, practices, policies of many institutions that generally lead to adverse conditions, adverse outcomes for communities of color in comparison to white communities. And this occurs within the context of racialized history, racialized culture. Next slide. So kind of going back to this, again, part of the discussion that the council had was, thinking about the different forms of racism, how this relates, and how it's often easier to recognize racism externally, recognize it in society, versus recognizing it in ourselves. And I do think that, surgeons, however, we should have a little bit of insight and advantage into that self-reflection because we're all raised in an M&M culture, and we know how much easier it is to identify others' mistakes and problems, but how important it is to kind of turn that reflection on ourselves to see what we could do better, what things we might be missing, and kind of make progress there. Next slide. So the topics that should be priorities, and the council has many, many DEI initiatives and topics that we think are very, very important. We really want to be effective for the department, and we want to serve the department. So this was of key interest to us in really understanding what resonated, what were the priorities for the department members. We let people choose 3, so hence our numbers here. But you can see right at the top, both coming in around 47 and 48% are recruitment of URM faculty and health disparities research. Next slide. Coming in right underneath that, right around the 35% range, the pipeline efforts in terms of outreach to students high school and younger, as Dr. Dick just referenced in his presentation. This is really a key section of the pipeline here. patient-facing DEI resources, and then mechanisms to increase retention of URM faculty and residents and fellows. This also brought up to the council URM as an acronym, and many people in the survey, especially in the free-form comments, noted that they were not aware of that acronym. They weren't used to that acronym and wanted a better definition of that. So next slide. It's a debated acronym, you know, and Dr. Dick also referenced this, but an underrepresented minority, someone whose racial or ethnic makeup is from one of the following groups. But you can see, even as we move, say, look at UCSFs to Caltech, really these groups change based on your location or your institution. Next slide. This caused the AAMC to kind of redefine their definition back in the early 2000s, around 2003, to underrepresented in medicine. So underrepresented in medicine means those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. And I think this is a good way to think about it. You know, look around at your professional world and your professional bubble, and then consider the community that you live in and the communities that you serve, and see if they match up. And if they're not really matching up, then what can we do to make that a little bit better and make that fit a little bit more? Next question. I'm sorry, next slide. I believe I have a good understanding of the health disparities that exist within surgery. So, you know, referencing the priorities again, health disparities research was, you know, very high on the members of the department's priority list, coming in very close to number 2. And this again, you know, touches on that. And the large majority of our respondents feel that they do have a good understanding of the health disparities that exist. But then again, coming in second is really that neutral number. And I think this is kind of a call to the council, really, that this is a huge area of interest, and that we could really work to create a stronger health disparities research program, create some infrastructure around that. That's also a way to open up some frank assessments and discussions of how we, as surgeons, are providing care to our patients here. So I think that's a good takeaway. Next slide. You can move past that one too. Okay, so, you know, this is an interesting slide. I believe that the department addresses equity, diversity, and inclusion effectively. So about 30% of us agree, and about 30% of us are neutral. And then beyond that, the response is pretty mixed. Next slide. So you can take these results in a variety of ways. You know, I think one way to look at it is that we are doing some really good work, but there is still so much work that needs to be done, and sort of a call to our future. Next slide. Okay, in the interest of time, I'm actually going to skip the next 2. Thank you. And I'm gonna, you know, kind of move to the free-form comments at the end. So at the end of the survey, and we asked if anyone had any comments, any experiences they'd like to share, anything on the topics, and we got many, many responses. And our intent is to do qualitative analysis on those responses, code them, so that we can present them in, you know, an easier to understand and really a more coded way. But even just reading them is very interesting. And so these are just 2, and they're 2 very different responses, but we thought they showed different thoughts and different ways that our department can think. So I'm gonna leave you a minute to read those. So next slide. So these are just a few of the questions of the data that we've collected from this survey. There are many, many more, and we look forward to sharing all of those, discussing them, analyzing with you, and our plan is to do this at a dedicated grand rounds in the early winter. We also want to post these in a format that you can review them on your own time, discuss them on your own time, and really get into that. So we're going to do that as well. I'd like to give special thanks to all the members of the Diversity Council who are really key in both the creation and the review of this survey, and specifically to the survey subcommittee members that are listed here. Thank you so much for your time.
Thank you to all the panelists and to all of you listening in. Dr. Davidson and I were asked to talk about some anti-racist initiatives focusing within the division, but also extending out into the department. Next slide, please. But I think a lot of people don't really know or understand what the word anti-racism means. And I think that definition is important. And it's really the recognition that it's not enough to be not racist. There is no neutral when it comes to racism or anti-racism. So that if you are not going to be racist, then you have to actively be anti-racist or to work against racist policies and racist institutions. Being anti-racist requires a persistent self-awareness, self-criticism, and regular self-examination. And as Dr. Reimel mentioned, that's actually something that we as surgeons are pretty good at in the way that we address disease, in the way that we address quality improvement and initiatives. And so we can take that same attitude, that same lens, and turn it towards ourselves and towards our institutions. Next slide, please. This is a slide actually developed by a surgeon, Andrew Ibrahim at the University of Michigan. In the interest of time, I'm not going to go through it all, but I think it's interesting to say that becoming an anti-racist is not a binary proposition. It's not all or nothing, and it's something that's a continuum that we are all working on. And you may find yourself at different times, at different points in this continuum. Next slide, please. The Division of General Surgery under the leadership of Dr. Olschlager has really committed to anti-racism, and I think hopefully will serve as a model to the other divisions within the department. I think the hallmark of that is that it's becoming an integral part of our faculty meetings and is becoming a regularly scheduled topic. And we're using that lens in a lot of our policy discussions, in our recruitment, and really in all of our efforts as it relates to everything from our clinical to our academic to our administrative roles. We have an active collaboration with the Diversity and Inclusion Council, including our division chief is an ad hoc member of the council, as are a number of other members of the division. And I think Dr. Dick talked about the importance of the formal mentoring program. And again, that's something I think our division is leading. We have a number of works in progress, and I certainly don't want to give short shrift to some of the work that Dr. Williams and others have done, but we wanted to talk about a couple of projects in particular. So next slide, please. So when we talk about becoming an anti-racist institution, the first step it really is education and examining that process of inclusion. I think it's important to recognize that oftentimes there's a minority tax in that those members of underrepresented minorities are saddled with the burden of explaining racism, of fighting against racism, of doing this work on their own. And it's important that that burden of the anti-racism work needs to fall not just on the burden, or not just on the shoulders of those experiencing racism, but really is all of our responsibility as surgeons and as leaders. We as surgeons are used to educating ourselves through mechanisms like Morbidity and Mortality Conference, through journal clubs, through research. And we're talking about a number of projects where we're sort of repurposing that framework to then turn that lens against a disease, the disease of racism. Next slide, please. So the first initiative that I want to announce today formally is our Anti-Racist Book Club. This has actually started discussions in our division, but we've opened this up to the entire department. All trainees, all faculty, and importantly, all staff in the department are invited. The goal of this book club is like a journal club. It's really shared learning and to develop a common language to talk about race. The book that we're going to start with is So You Want to Talk About Race by Ijeoma Oluo. She's actually a Seattle-based author. And this is a great book because it really does help set that framework. It's important, though, that self-education is necessary but not sufficient. And it's not enough to just talk. We actually have to identify action items. If I could have the next slide, please. So going out today is an email inviting all of you to sign up for the book club. It's already gone out to the residents and the staff, and it's in the, I think, the mail queue to go out to the faculty. So if you're multitasking today, please sign up via the survey. And if you want to order the book, I would recommend supporting Estelita's library. The Seattle Public Library also has free copies for audiobook. And we're going to make a limited number of free copies available, hard copies for our residents and staff to help them get this important book. Next slide, please. I do think it's, again, important to recognize that words aren't enough and action is important. I'm not going to read this, but I think it is very profound. And just joining a book club to make us as feel better, and by us, I mean the majority, the white faculty members feel better, is not enough. And we really just need to use this as a launching pad for further action. Next slide, please. I'm going to turn this over to Dr. Davidson now to talk about a couple other initiatives.
Thanks so much. And I'm going to go through these fairly quickly because we're going to be sending out more information via email, and you'll hear about it in your individual divisions. And I want to make sure that we leave appropriate time for the rest of the speakers today. So like Dr. Reimel said, you know, surgeons are really used to evaluating their own complications and the ways that systems fail and the way that we fail in a way that is introspective. But we don't do this about difficult conversations around racism, around sexism, around how we negotiate both with patients, but also, you know, within our professional societies. And so this winter we'll be launching a curriculum called Cultural Complications that was originally started by surgeons in Maryland, has now expanded to both Michigan and Duke. Next slide, please. And this is a group of formal cases that have been developed that really mirror situations that many people have been involved in. And they range from everything from bias, discrimination, and actual racism, and not seeing someone as human that you're taking care of, that they have a differential outcome for. And then it ranges from topics like you're invited to be on a panel and it happens to be a manel. What do we as a community agree is the most appropriate vision? And it opens up areas for discussion as a group. So this will be launching in the wintertime. Next slide, please. In addition, we're going to be launching a bias reporting tool. This is coming out of the Office of Healthcare Equity, led by Dr. Paula Houston. And one of the things that we've recognized is while there's a ton of ways to report different issues that are going on across our campus, there's not a way to report the things that impact the climate, like 100,000 mosquito bites. And so the system as a whole is really looking for ways to try to measure and identify hotspots to then feed back to different organizations around the community to be able to do interventions in real time. Next slide, please. So this bias reporting tool should come out probably in the next month or so. You'll see a link to it. You'll see a link to actually a number of different tools that are being launched across the medical school, across GME. But all of these are hopefully going to allow us to see better in real time what's happening and to be able to intervene. Next slide, please. Andy and I just want to take a moment to thank the members of the Diversity and the Inclusion Council. The leadership of this team includes faculty, staff, and residents, many of who you know, but I don't think that we always recognize all of the amazing work that's been going on for many years. It's important to acknowledge that while they've been doing this work, anti-racism has really become a hashtag, and now it's trending. And too many of us in the department have really been passively on the sidelines, thinking about this as being somebody else's job. Maybe we're just not an expert ourselves. We haven't taken the time to dig in and really evaluate what our own role is. Or maybe we didn't consider that racism was an issue inside our own institution. But for us to really accept that racism is a disease, anti-racism has to be an active process, and it can't be shouldered just on one group. It has to be incorporated into every aspect of what we do, from the patient care access to evaluating our clinical outcomes, to how we interview residents and candidates, how we support or mentor each other, and in our research. This has to really be all of our work. So I'd just like to take a moment and thank you, Dr. Reyes, and all of the members of the committee for your leadership over many years.
Well, I appreciate all of the colleagues who went before me to set this wonderful platform for me to discuss, myself and my husband at Willando, to discuss the Healthcare Workers March for Justice that was led in June. And we definitely want to get to Dr. Cornwell and his comments today. Thank you so much for joining us. I really have been inspired by your work over the years as both a medical student and a junior faculty member, especially as a woman of color, a Black woman in surgery. And I want to hopefully set the tone for the historical perspective around why this work is important. I'll let my husband introduce himself for those who may not know him.
Sure, good to see everyone. Professor Edwin Lindo, sorry I didn't provide the updated titles. It's been a busy week, so thanks for working with us. But most recently, the Assistant Dean for Social and Health Justice within UW School of Medicine, and acting assistant professor in family medicine with the focus on critical race theory as the foundational lens through which I do this work to support you all and our students.
Next slide, please. So I'm actually leading with a slide that I presented in 2018 when I presented back at Harkins around an update for the Diversity Council. And I'll read this quote to you from Maya Angelou. I was told many years ago by my grandmother who raised me, if somebody puts you on a road and you don't feel comfortable on it, and you look ahead and you don't like the destination, and you look behind and you don't want to return to that place, step off the road. And I would like to commend this department for stepping off the road. I have to impress upon you all that when I presented back in 2018 for the Diversity Council, it was very uncomfortable, mainly because this was not a common conversation that we were having around diversity, inclusion, and race within surgery, and what its impact is on trainees and faculty. Now, given the social uprising and everything that's happened within the world around us this past year, all of this stuff has come as a Mack truck hitting us all in the chest, and we all feel it. Some of us take it home more than others. And to be in this place now, in 2020, it is a much different place than what I was in 2018 presenting these topics. It is a place where we have welcomed these conversations. We have pushed ourselves to address these things head on and not hide behind our profession as surgeons to say, this is not my job, this is not my place. We have all owned this as a human condition that must be addressed if we are truly committed to taking care of those who need the care most. So I want to thank the department for stepping off the road and blazing a whole new trail. Next slide. The reason that this march came to be came from a very personal experience. And it came after the killing of George Floyd. And this wasn't the first time that we had been involved or addressed issues of police violence as a public health crisis within the United States. When I was a resident, my husband spent 18 days on a hunger strike outside of the Mission Police Department on Valencia Street in San Francisco. I spent my vacation time with him on that hunger strike, camped out in a tent while he fasted for 18 days. And that was after there were a number of extrajudicial killings of Black and brown individuals on the streets of San Francisco. The result of that hunger strike was the firing of then Police Chief Greg Suhr. This has been an ongoing struggle within our wheelhouse, within our communities. It has been a passion of ours for years. And the killing of George Floyd brought to a head something that we had been fighting for years. And I was very excited and I was very humbled by the response of our department to at least acknowledge that these things were happening and to acknowledge the feelings that individuals who are most impacted by them could be feeling. And I think the hard part is that we talk about these incidences as if, they happen a world away from us. And we don't understand sometimes that these experiences live in the individuals that we spend time with day in and day out. And I shared some of those experiences in that letter. What I didn't share, because the letter would be too long, were my own experiences with being pulled over by the police. Every time I drove into the town that did not have many Black and brown residents. I had my 86 Ford hatchback. That was my very first car. And because that neighborhood was a neighborhood of affluence, and I would go and pick up my friend from work, every night I went to pick them up, I was pulled over by police. I didn't talk about the experience of being a medical student here at the University of Washington. And there was an extrajudicial killing of a Black man by King County sheriffs in Burien. And I was on my pathology rotation through the King County Medical Examiner's office. And the experience of picking bullets out of that dead person's body, that Black man who had died unnecessarily. And I want to make for sure that we acknowledge that this is what we mean when we talk about systemic racism and institutionalized racism, how our police system here was created as slave patrols in order to police Black bodies who were brought here to the soil, to stolen land here. And we have always been considered property and individuals to be policed. And that feeling doesn't go away just because you attain a certain degree. That feeling doesn't go away because regardless of what happens when I step out into the street, when people will see any of my family members, they see our skin color first. And we cannot go by our day without acknowledging that that is the experience of so many people who walk this earth and walk the streets around us and live in our communities. And that is the existence that they have to experience. And so I want us to spend some time about the demands that were put forth and what actions came about that.
Right, next slide. So what occurred, as Dr. Williams mentioned, was a confluence of consistent, perpetual, and a legacy of state-sanctioned violence, which is police killing, police brutality occurring in Black and brown communities, particularly on Black folks. And it shows the direct contrast of justice and why the anger is fueled, and in many ways why the anger becomes something that we get accustomed to and we get dulled to. And if you're not familiar, we have Breonna Taylor in the right here. And Breonna Taylor was a paramedic, one of our colleagues who was in her home. Police showed up to her home and killed her effectively in her sleep with her partner laying next to her. And there's a number of other facts that I won't get into, but I want to say that you contrast that then most recently where 2 police officers who allegedly beat Porcupine to death while on duty have been fired within 7 days of that incident. The police who shot and killed Breonna Taylor have never been fired. They still have a job. The insanity that this can occur, that this is allowed, and the value that it shows of Black and brown folks is evident and clear. And we have to hold that. We have to understand that when Black folks see this disparity and inequity in outcomes, both in the judicial system, in the hospitals, it isn't that they're mad in the moment or they're mad at you, is that there is a lingering, perpetual anger at a country that sole purpose, when founded, was to create chattel slavery. And that chattel slavery was on the backs of stolen land from indigenous people and labor forced upon Black folks stolen from West Africa. This is a fundamental tenet that we have to understand if we're going to understand how we address racism. And so if we can go to the next slide. If I can get to the demands, I won't go through all of them. It's long. Hopefully some of you have read the letter. If you haven't, I think we can send it out again. But at its core, these are demands that were borrowed almost verbatim, except for a couple that were added to be Seattle specific, from the APHA's demand that police violence is a public health epidemic, that we must treat it as so, that we must have policies that investigate, that address, and that create safety in our communities, and that it calls upon the medical community to take a stand that police violence is something that we must be in conversation about, that we must take a position on, because if we are actually caring about our communities and our patients, then this is a direct effect on our communities and our patients. And we give a quick statistic, 1 in 1,000 Black men are gonna die at the hands of police in this country. That is a devastating statistic. That is a statistic where we have people dying at lower rates of measles, a common disease, than we are at the hands of police. That means we must now pathologize the racism that is occurring so that we can interrogate it to fully address it. Next slide, please. And so what is happening now? What's happening now since the letter, since the 10,000 people that came out, many of you were there and we appreciate the support, is that it created a crest of inertia and movement in working with community like King County Equity Now, which is a coalition of community organizations around Seattle and King County. And what they've been able to do is reallocate funds from policing in King County and Seattle, and is now being invested in community research, upon which we are a part of, where we are looking at alternatives to public safety and community safety with less policing. In addition to that, there has now been an uplift and a centering of Black-owned businesses. And what we encourage folks is another way to be justice focused is understanding the legacy of stolen opportunity, of generational wealth. How do we then give back? How do we at least try to mitigate that? One thing that we do as a family is that every opportunity we have, we ask the question, who owns this business? Whether it's the toiletries in our house, the cereal we buy, the syrup we buy, we do our best to buy from Black-owned businesses or Brown-owned businesses. And it's difficult because it takes a bit more work, but it's work that I think we can all do. And it's a small step, but it's a step that I think makes a substantive change. And if you want to talk about the trauma-informed care that we're also working on.
Yeah, and so there are a number of initiatives that are just starting to break ground, but also working within the surgical community and within our space here to provide education and policy around trauma-informed care, especially given the recent uptick in gun violence and the number of Black youth have been suffering at the hands of gun violence, and how we can better support community through advocacy and policy within our health systems. And so more of this will be forthcoming, but just know that those are other initiatives that are happening right now as well, because there is often a interplay of the poverty and gun violence that we see that perpetuates not only just police violence, but gun violence within the communities. And there is a concerted effort to address all of those, because it isn't just one. We're not just focusing on police violence. We're looking at how do we uplift community wholeheartedly. And so we can finish up with the next slide. And so I just want to leave you all with some photographic representation of what we as a collective can do when we come together. That there are so many of us who see these images and see what's happening in the world around us and want to impact change and want to be a part of that. And we thank you for going on that journey with us and being a part of that this storyline that we will continue, that is continuing to unfold, that will continue to change the material conditions of those who are most marginalized. And we appreciate having the support of a department and of individuals who care so deeply for those who have been forgotten for so long. And the one last comment I want to make is that, when we talk about this space, we focus so much on really uplifting and talking about the Black voices that have been forgotten. And I always like to impress upon people that, when we uplift those who are most marginalized, everyone benefits, everyone gets justice. The story of Breonna Taylor is one that is within the community of Tennessee, but we have our own stories right here in our backyard. We have the story of a Vietnamese high schooler who was gunned down by a King County sheriff the day before his high school graduation, Tommy Lee. And the family is still fighting for justice here. He was holding a pen in his hand. The police officer thought it was a knife. And that 17-year-old kid died the day before he was going to graduate from high school. And so this doesn't just impact the Black community, but when we raise our voice and say, these are the horrible statistics, these are the most marginalized that are most impacted, how can we find a way to address this injustice? All of those who are also being impacted, the white individuals who are killed by extrajudicial killings by police officer, our Asian brothers and sisters, our Native American brothers and sisters who are also killed at even higher rates than Black individuals. All of those benefit. And so we appreciate you, we thank you for your time, and we look forward to the conversation.
The last thing I'll say is in this picture, I want you to see the thousands of people that showed up. There's an estimate of 10,000 people that arrived at the protest. And there may be some people on this call, and there's people who have said it to my face that said, Edwin, we have no role in being political. And there's two things that I want to say on that point. Is one, medicine has proven already to be political, and its political stance has been to be oppressive on melanated people. Number two is that this is not about politics, this is about policy. The number of feet that are walking in those streets in these pictures you see changed policy. They changed policy in King County, in Seattle. It created other movements around the country for white coats to come out en masse. It is powerful when we get our voice out outside of just the clinic walls.
Thank you.
Good afternoon, everyone. It's a sheer honor to have been able to take part and witness that last section. I applaud you, Dr. Wood, Dr. Wu, thanking you all for the invitation, for the opportunity to share in this. And I'm going to get right in because hopefully based on the tail end of what I just heard, I hope some of the history of Dr. Charles Richard Drew serves as a little bit of stimulation, as it does for those of us that have either been students or residents or faculty members or even chairs here at Howard University. And so with that, and with the assurance that it's not just a perfunctory thanks for the honor of giving the Harkins lecture, let me start in and tell you a little bit about Charles Richard Drew, who is a contemporary of Henry Harkins, born a year before Dr. Harkins was, here in Washington, D.C. He went to public schools, Dunbar High. In 1922, there was not the term that we might be used to today of magnet school, but blacks going to Dunbar High School in the 1920s, most of them went on to college. Dr. Drew was a accomplished student athlete, and he went to Amherst, where he ran track at Amherst. I'm going to mention a couple of his. There are 3 black members on that track team. Montague Cobb was his high school classmate as well, also a Washingtonian. I took Dr. Cobb's granddaughter to my senior prom as an aside, but Dr. Cobb was the emeritus chair of anatomy when I came here to Howard University Med School. And when I was 16, in high school, Dr. Cobb took me to a Amherst alumni play, trying to convince me to go to Amherst instead of Brown. I chose Brown. Dr. Cobb was very understanding, but Mrs. Cobb never forgave me. But Dr. Drew, Charles Drew, had a productive experience at Amherst. It's thought that his schoolmate, the son of President Calvin Coolidge, who stepped on a rusty nail and died of a staphylococcal infection, that experience is thought to have stimulated Dr. Drew's interest in medicine. When he was ready to, upon graduating Amherst, when he was ready to apply to medical school, America looked very different after the 1910 report by Abraham Flexner, which kind of standardized the resources, the curriculum, the commitment of faculty that was seen amongst medical schools or institutions that called themselves medical schools. And the impact of the Flexner report is virtually half of medical schools in America closed. And only 2 of those 9 land-grant institutions that were established after the Civil War that trained medical students of color, Howard here in Washington, D.C., and Meharry in Nashville, Tennessee, were the only 2 that survived the Flexner report. And so not surprisingly, they were statistically among the most competitive, as virtually every Negro pre-med student in America between 1910 and really right up until through the 1960s would be applying to Howard and Meharry. So it was with Charles Drew. Had an admirable career as a student athlete, and yet the 6 English credits that Charles Drew had were too shy of the 8 required in the inflexible admission standards at Howard. They could afford to be inflexible, and that story repeats itself. There are many well-established and well-accomplished surgeons and physicians that I know of my father's vintage who did not gain admission to Howard or Meharry. So Dr. Drew had to go out of the country. He went to Canada. He attended McGill in Montreal, where graduate students could participate in track, and he established records there that would last for decades as a track athlete. He finished 2nd in his class, and the top 5 students finishing in the class all took part in a writing competition, and so Charles Drew won that prestigious Williams Award in the class of 1933. when you look at some of the training, in the first third to the mid part of the 20th century, when we look at the history of majority institutions integrating, even at medicine, there was a barrier that was even more elusive than the occasional Blacks, and I'll mention some of these examples, the occasional Blacks that went to schools other than Howard and Meharry throughout the Northeast, the Midwest, that had integrated even before the Brown versus Board of Education Supreme Court decision in 1954. But even in those schools that had integrated, the most elusive barrier to cross would be training in those hospitals. Even if an occasional medical school was graduating and doing well in his or her class, mostly his, you will not see many of them going on to stay at that hospital where they would give orders to white nurses and treat white women. So that was probably the last barrier as it relates to diversity and inclusion in American medicine. But Dr. Drew did get some training in Montreal General Hospital, both in pathology and medicine. He came home back to DC when his father died in 1935, spent a brief time first as instructor in pathology and as a resident in surgery when the surgical residency program here at Howard, then called Freedman's Hospital, was just established in 1936. A pivotal year in his life after spending a year as an instructor was the opportunity through a Rockefeller Fellowship grant to go to Columbia University and continue some of the work that he had done, research in the area of shock as well as plasma extraction and preservation. Now, this preservation of plasma proteins was critical, pivotal work in the decade before America became involved in World War II, because that ability to store plasma and transfuse blood for we trauma surgeons takes our resuscitation to the next level, and the numbers of patients that could be saved expands exponentially. One of the major advents in the 20th century. Before that time, if a patient, for example, had a gunshot wound, a troop had a gunshot wound, it was 70 kilograms and lost 1,500 cc's of blood, the overwhelming majority of those soldiers would have died. So Dr. Drew worked in the lab of John Scudder in the Department of Surgery at Columbia University. The chair was Alan O'Father Whipple, and Dr. Scudder had description of Dr. Drew that was full of hyperbole, a naturally great, intelligent person with a retentive memory. And I love this, a biologic clock of untold energy. Personality altogether charming, flavored by mirth and wit. He became one of the great clinical scientists in the first half of the 20th century. Dr. Scudder's words about Charles Richard Drew. And uncommonly, now this is even in New York City in 1938, for a Black to gain a residency position in the clinical residency program was remarkably unique. Dr. Whipple, when such a thing happened, and Dr. Whipple gave Dr. Drew that slot for a year, his letter of instruction stated, provide him meal tickets and uniform. He's not to eat in the dining room with other residents. I cite this a lot. Somebody spoke today about the color tax of when you're usually on the admissions committee and diversity committees. I've been on all of them at Hopkins and at USC. And I often tell people this story about Charles Richard Drew, because after 1 year as a resident, he was reappointed to a second year. And the chair, I don't know if that's good grammar, but the chair at that point says he's done an outstandingly good job. The residents insist that he eat in the dining room with them. And I often think about that. Did those residents just get morality after 1 year in New York in 1938, 1939, 1940? No, I think they wanted to be around this guy with the biologic clock of untold energy, with this personality marked by mirth and wit, one of the great surgical scientists. And so it is, we should state explicitly what we know implicitly, that the goals of diversity will not be achieved if it's about white guilt or quota, if it's about anything other than what Dr. Drew spoke of, which is excellence of performance will transcend artificial barriers created by man. I will be making the case that my hero and mentor, Dr. LaSalle Lafall, who was a student of Dr. Drew's, kept that mantra alive. And so there are students, former medical students like myself, who were born well after Dr. Drew died, that will automatically connect that mantra with Charles Richard Drew. Excellence of performance will transcend artificial barriers created by man. Their paper on preservation of blood, a critical move to allow us to store plasma and to transfuse blood for the first war during World War II, it was published the year before Dr. Drew directed, the year of and after Dr. Drew directed the Blood for Britain project by sending stored plasma overseas to Europe. That paper was presented at the American Surgical Association in 1940 in St. Louis. It's likely that Dr. Drew did not attend that paper, but he was the senior author of the paper. And he also, it was the subject of his thesis for which he got a Doctor of Medical Science, a study of the problems associated with blood preservation, the work that he did in Dr. John Scudder's lab at Columbia University. I know the students, residents, and even younger faculty don't remember a day when you're writing a paper and you had to go to a library to do a literature search, but 15 publications on shock, fluid, and electrolytes for Dr. Drew and plasma preservation over a 2.5-year period was, and while he was directing a blood bank, was prolific in those days. Dr. Drew came back to DC in 1940 and had another very brief hiatus where he is asked to direct the precursor of what we now know as the American Red Cross. This would be in 1941, as not knowing that Pearl Harbor was going to occur in December, there was certainly some sentiment that America would be drawn into this war. And for just a couple of months, Dr. Drew directed what would be the American Red Cross Blood Bank. Dr. Drew was a humble man despite his enormous contributions. And he would never have publicly criticized the US Department of Defense in advance of America entering the World War. But he had private letters that made it very clear that he was totally against the Department of Defense's policy of restricting blacks from donating blood initially. And then they modified the policy to let blacks donate blood, but they separated the blood the same way that they separated human beings. And Dr. Drew privately wrote 3 things, 3 bullet points. 1, there's no scientific basis for the policy. 2, that no tool of the American government should humiliate a component of its population. And 3, which I think is elegant in its simplicity, we need the blood. So Dr. Drew directed the blood bank, but he could not give to the blood bank. And in the spirit of the day, let me just point something out about this. Look at the skin tones of these black residents. There's a few Filipinos, of these quote unquote Negro residents that trained under Dr. Drew. You know, in the spirit of the openness with which you all have discussed challenging topics, let me do the same. I got a letter one year when I was the secretary of the Society of Black Academic Surgeons, an anonymous letter from someone who emailed it and said, who's the white guy on the cover? And certainly Dr. Drew has fair features, straight hair, fair skin complexion, and that's not a coincidence. You know, when you look at the surgical pioneers of color who would have been born in the 1880s through the 19-teens up to 1920 or so, you're talking about people that would be the sons and grandsons of slaves, but they also in many cases were the grandsons and sons of slave masters. And it's not a coincidence that many of the early pioneers will more likely have features like that than to look like uncompromised phenotypes of those slaves that came off the boat in West Africa. Remember the Middle Passage stopped in America in the 1830s. So for over some 30 plus years, that labor intensive industry throughout the South, including picking cotton and tobacco fields, relied on procreation between slaves and slaves, but also between slave masters and slaves. And so when we talk about the science of diversity and we look at clinical records that speak as a binomial, it obviously is not a binomial. It obviously is a social construct, although In some cases, it's a binomial social construct in the sense that if a slave master and his slave conceive a child, that baby is a slave. And if that baby grows up, obviously in slavery, and her master conceives a child with her, that child has 3 European grandparents and 1 Black grandparent, and that child in America has always been called Black. And so integration, segregation, Jim Crow, slavery is a yes-no proposition. It's a social construct that frequently has many binomial implications. And so it's not, and so that person that wrote that letter to me that day, when I had a chance to respond, and I pointed out that when Dr. Drew and his 2 Black teammates at Amherst, however he looked, traveled to Providence to participate in a track meet with my alma mater, Brown University, they had to travel separately, stay in separate hotels, and eat in separate restaurants. So in Rhode Island, and so he obviously looked Black to somebody. He couldn't go to medical school in America. He had to go to McGill in Canada. He obviously looked Black to somebody. And so it is, that's a point that is frequently missed when you look at the phenotypes of some of the early Negroes that had the opportunity to go to medical school, get training at one of the 8 or 9 hospitals through the first quarter of the 20th, through the first third of the 20th century that will train professionals. Dr. Drew, as I mentioned, he comes back to DC, and in 1941, he's appointed chair of the Department of Surgery. The most consequential president in the history to date, in the 152-year history of Howard University, which was signed by a charter by President Andrew Johnson on March 3rd, 1867, was probably Mordecai Johnson, who was the president from 1929, can you imagine, to 1960, 31 years, can you imagine? Very fair-skinned himself, a graduate of Morehouse himself. But by the time he gets into the 30s and 40s, there's becoming a critical mass of professionals in multiple disciplines. And Howard, as a university, had 13 colleges, the only land grant of those so-called predominantly land grant institutions that later were called HBCUs, that had a dental school, for example, a business school, a law school, a medical school, and several others, theology and so forth. And so President Mordecai Johnson's vision was very clear. As he started to have deanships and major chairs positions open up, he would search for the most qualified Black academician to fill that chair. And so it was in 1936 when the Department of Surgery, established in 1868, had 5 of their 6 chairs, but up to that point, the first 70 years were white. A white Yale-trained surgeon, Edward Howes, signed a 5-year contract to be chair of the Department of Surgery in 1936, the year our residency began. And after 5 years, it was clear that the most qualified Negro surgical academician would succeed him as a chair, and that was clearly Charles Richard Drew, 1941. This historic photo is from the University of Michigan class of 1941. They had 4 Blacks graduating in the class of 1941. I call your attention to the gentleman on the far left. Asa Yancey was his name. The woman on the far right, Maggie Williams, trained in pediatrics, lived and worked in Chicago. The 3 men, Asa Yancey to your far left, Charles Sutler next to them, and C. Waldo Scott next to him, all came to Freedman's Hospital to have some of their training under Charles Drew. Class of 1941. C. Waldo Scott, for you C-SPAN fans, looks just the spitting image of his son, Bobby Scott, who's a congressman in Eastern Virginia. He's Dr. Britt's congressman, as a matter of fact. They are spitting image of one another. And so there were the occasional Blacks that went to school other than Howard or Meharry. This is 1941, and they weren't the first. Asa Yancey's older brother, Bernice, graduated in the class of 1930 at the University of Michigan. But he didn't train. He didn't train at that hospital. He trained at Negro Hospital No. 2 in St. Louis. And tragically, despite beating all the odds in society, as a brilliant youngster coming out of Atlanta, going to Michigan med school, handling faulty equipment, X-ray equipment in 1930 at that hospital in St. Louis, got electrocuted and died. And so the family focused their interest on his younger brother, 11 years younger, Dr. Asa Yancey, who also born in Atlanta, valedictorian of his class in Morehouse, and graduate of class in 1941, University of Michigan. He's got, like other blacks, they got to cobble together some training. So he spent a year at a hospital in Cleveland, and he came to train under Dr. Drew, and many people think that Dr. Yancey was Dr. Drew's most accomplished trainee. After his training, and training was accelerated in the 1940s after America entered the war, there were 2 med school classes at Howard in 1944, and there were 2 residency training classes, graduating class in 1944, producing surgeons and physicians for the military. He spent the better part of 1945 at the U.S. Marine Hospital, and because Howard had a well-operating OBGYN service, Dr. Yancey wanted more pelvic surgery experience and went to Meharry and got it. And that was an important time, because after that stint, with Dr. Drew's help, Dr. Yancey became the chief of surgery at a VA hospital in Tuskegee that was built in the 1920s. The Ku Klux Klan was not pleased about it, but took care of and trained, took care of black VA veterans and trained blacks in their training programs. That's also the hospital, the infamous Tuskegee study as well. But Dr. Yancey became the program director and the chair of a program in the Deep South, and this would happen also when he returned home to Grady Hospital in his native Georgia, program for blacks and Filipinos that trained in the late 40s and the 1950s in Alabama. Also, they had an outstanding veterinary school there, and because of that, Dr. Yancey perfected a procedure that was applied to patients with aganglionosis of the colon. Now, my pediatric and colorectal surgical colleagues know that to be Hirschsprung's disease. Initially, the Swenson's operation removed, and it's the rectosigmoid that is devoid of that neurogenic plexus in the submucosa, and so the normally innervated, more proximal colon gets dilated because of the functional obstruction that's distal to it. And so originally those patients would have perineal resection and a lifetime colostomy. Dr. Yancey's modification was to strip the mucosa and the submucosa of the rectosigmoid and pass the more proximal colon down through that seromuscular sleeve and fashion a perineal anastomosis. Performed that in dogs, and performed the first one described in the literature in a young girl who survived the operation and almost a year later died, unfortunately, of a garden variety postoperative small bowel obstruction. But he published those results in the Journal of the National Medical Association in 1952. Dr. Drew would not live to see his prize pupil publish that. But the Journal of the National Medical Association, remember the American Medical Association didn't have any blacks in it. So the Journal of the National Medical Association probably was not in the library of most majority institutions in 1952. But Dr. Yancey published that paper there 12 years before. And I know you all think that sounds like the Suave procedure. Yeah, of course it's called the Suave procedure because Dr. Suave published the same procedure 12 years later. Hirschsprung's disease, a new, I'm pausing on purpose. There's no mute here. I don't believe you heard. A new surgical technique. 1952, 1964, a new surgical technique. Now, when I say that, tell this story to our new interns, one year, about 7-8 years ago, an intern raised her hand. She said, isn't there somebody that, someone who's, some society that is formed to write these laws? I said, yes, you're part of the society. Welcome to it. If you don't pass the word, who's going to do it? Hirschsprung's disease. In fact, Dr. Yancey, of the three papers that were used to support his admission to the Southern Surgical, he was the first black member of the Southern Surgical. His chair, Dr. Dean Warren, he also was the first black on the faculty at Emory. He integrated, when Grady Hospital did integrate, he integrated the faculty at Emory. But this was one of the papers that used to support his membership in the Southern Surgical. Dr. Drew's vision was unambiguously clear. He was geared towards a more perfect society, a more complete society, by training the best qualified and best trained Negro men, they were all men during his time, and have them go out to other hospitals throughout largely the 1940s and to integrate that. And that's exactly what happened with Dr. Yancey, although Dr. Drew would not live to see it. And Dr. Harkins spent some of his time at Johns Hopkins, and Dr. Harkin also did some of his research on many things. When you look up among his 340 publications, Dr. Harkins wrote about shock as well. And Dr. Drew lectured on this in the physiology class. So he, as the chair of surgery, also lectured in the preclinical class course of physiology given to second-year medical students. And one such brilliant second-year medical student was Dr. LaSalle Lafall, known to many in this audience. Dr. Lafall died 3 days after his 89th birthday last year in May of 1989. But Dr. Drew, as Dr. Lafall pieced together about the last 24 hours of Dr. Drew's life, he rounded with the residents in the morning, did a radical mastectomy, and at 10 o'clock, how about that, guys? You got a lecture to give at 10, your case is scheduled at 8. They probably started on time for the chair. So he did his radical mastectomy, gave his lecture on shock, blood plasma, and water balance to the physiology class, to the class of 1952. This was March 31st, 1950. And sitting in the front row of that lecture was a precocious 19-year-old sophomore medical student. I feel such an underachiever. 19-year-old sophomore medical student, Charles Richard LaSalle Lafall. He always sat in the front row. Now, Dr. Lafall, by the way, almost didn't gain admission to Howard. Dr. Lafall, at the age of 15, entered the freshman class at Florida A&M, as did my 93-year-old mother. She was 18, he was 15. She graduated in 4 years, but Dr. Lafall graduated in 3 years. At the age of 18, he was the #1 pre-med student coming out of Florida A&M and couldn't even get an interview at Howard University College of Medicine. Can you imagine? But the university president, Dr. William Gray, spoke to his counterpart, Mordecai Johnson, about his top 2 pre-med students coming from a school that didn't really emphasize what we now call the MCATs. And so their scores didn't meet that level that would gain them an interview. Can you imagine a college president lobbying his counterpart on behalf of 2 pre-med students? But that's what happened. George Rawls and LaSalle Lafall got an interview in 1948. They got admitted in 1948 to the class of 52, and I'll just cheat at the end of that story. They were the #1, Dr. Lafall and Dr. Rawls were the #1 and #2 ranked members of the graduating class of 1952, and they almost didn't get interviewed for it. Who spoke at their commencement in 1952? President Harry Truman, and he touted their accomplishments. So sitting on the front row, March 31st, of that physiology lecture given by Dr. Drew, was that young, precocious 19-year-old sophomore medical student, LaSalle Lafall. Dr. Drew then went to have lunch, some surgery department business. In 1949, he had gotten awards from both the student council and the nursing sorority, and he promised them he'd return the next year to give talks, and he did that, went to both banquets, and late that night made rounds, no 80-hour work rule back then. The residents rounded with him, and he leaves DC a little before midnight. They're going to a clinic that is held, and believe it or not, in 1950, it was integrated. In segregated Alabama, the John Andrews Clinical Society had meetings that both white and black surgeons would come to down in Tuskegee, demonstrate surgical procedures, give talks. His former resident, Asa Yancey, was the chair there. And so he's going to drive. Now, in 1950, Dr. Drew could have flown, but there were 2 young residents that were looking for further training, and a faculty member, Dr. Samuel Bullock, were all going to go with him. So they drove. Interstate system is not, President Eisenhower is not elected till 1952. So we don't have an interstate highway system yet. So before black travelers traveling into the South have to make plans well in advance of what they're going to do. And their plan was to leave DC around midnight, drive to Atlanta, freshen up at a YMCA, and then go from Atlanta over to Tuskegee, Alabama. And so they did. The 4 of them, the chair, another faculty member, and 2 residents. Dr. Drew took the wheel and was driving. This is not a 1949 Buick Roadmaster, Dr. Bullock's car, but I demonstrate this to show you Dr. Drew was driving. Dr. Bullock was in the passenger seat in the front, and the 2 residents in the back. When Dr. Drew fell asleep. This is John Ford, the intern, who I interviewed in 2004, 54 years after this event. He was the last surviving member that was in the car that night because Dr. Drew took the wheel around 5:30 in the morning, fell asleep on the road, Alamance County, North Carolina. And Dr. Bullock said, "Charlie, wake up." And when Dr. Drew woke up, he drastically corrected the course of the car off the side of the road. And that correction made the car swerve and ultimately flip over. The two residents were thrown from the back of the car. Dr. Bullock was lodged under the dash uninjured, but the weight of the car flipping over and ultimately landing upright came down on Dr. Drew's head and chest, suffering massive brain injury and traumatic asphyxia. Dr. Ford was one of the co-authors of that paper I just described, because he did get a job at Tuskegee. He did work with Dr. Yancey, and he was a co-author on that paper. And when I had an opportunity for the Southern Surgical Society History of Surgery grant to talk about Charles Richard Drew, I spoke of Dr. Ford and Dr. Yancey also. Dr. Yancey, his resident, Dr. Ford, his intern, who would go on to get further training under Dr. Yancey. When I spoke to Dr. Yancey about Dr. Drew that same year, 54 years after the event, and we got to that night, Dr. Yancey, who was at that time in his late 70s, broke down with emotion, 54 years after the event. Dr. Ford spoke of the fact that everything that could be done was done for Dr. Drew, dispelling a myth that had occurred. So Dr. Drew took the wheel at 5:30, the crash at 7:50, taken to Alamance County Hospital, massive injuries at 8:30, and pronounced dead just after 10 o'clock on Saturday morning, April 1st. Dr. LaFall himself, over the later decades, had an opportunity to speak to some of the people in the ER, a surgeon and Charles Cornodal, an orthopedic surgeon, and his brother, a general surgeon. Lucille Crabtree, the nurse anesthetist. These were the injuries for Dr. Drew. And so back on April 1st, 1950, when Howard Medical School still had lectures on Saturday mornings, Dr. LaFall was sitting in his usual front seat when the message about Dr. Drew's death came in to the class.
Students don't have class at Howard on Saturday night at medical school, but when I was a second-year student, we had class on Saturday. And I can remember very well, we were having class in the medical school. Dr. Walter Booker, professor of pharmacology, was lecturing to us. And I used to always sit on the front row because I didn't want to miss anything. I'm sitting on the front just writing all these notes. And a person came in, I think it was somebody we called Long Tall Miller. Miller was about 6'4", that was Long Tall Miller, a laboratory technician in the Department of Pharmacology. And he whispered something to Dr. Booker. I couldn't hear what he said. I'm on the front row, but I still couldn't hear what he said. But Dr. Booker's face turned ashen. And he then turned to Miller and said this: "You shouldn't joke like that on April Fool's Day." And I can always remember that because it was April 1st, 1950. I was a sophomore medical student. He said, "You shouldn't joke like that on April Fool's Day." And what did Miller say? He said, "Oh, I wouldn't joke like that." In other words, you might think about saying something about you left the lights on and all that, but you're not going to say the chief of surgery was killed in an automobile accident. So Dr. Booker then turned to us and said, "I have some very sad news for you. Our chief of surgery was just killed in a tragic automobile accident just outside Burlington, North Carolina, on his way to a medical surgical meeting in Tuskegee, Alabama. Class is dismissed." It was just hard to describe the way we felt. This man was so big, we wondered if the medical school would survive. Now, we know full well that no one person is bigger than any institution. We know that. But still, he cast such a giant shadow, such a big shadow, that we were wondering, could the medical school survive? Well, obviously, it did survive, but that's how we felt, just totally saddened. And how could this be? And that was it. A Saturday morning, April 1st, 1950, in a class in pharmacology, being lectured by Dr. Walter Booker.
There are many people to this day, 70 years later, that think that that segregated hospital turned him away. An episode of MASH, Time Magazine, New York Times all spoke to that. There are still people that think that. And no one did more than Dr. LaFall. During his 57 years on his faculty, I can personally tell you that generations of medical students that went to Howard can tell you, thanks to Dr. LaFall, the day that he died, you shouldn't joke that way on April Fool's Day, April 1st, 1950. And that everything was done. And Dr. John Ford told me the same. As I said, the last living person in the car. Dr. LaFall also spoke to that nurse anesthetist.
And going there, I found out that when Dr. Drew was brought in, that they knew that he was coming. But I should mention this, because when I was there was a lady who was a nurse anesthetist, Miss Lucille Crabtree. She was not there when I went down there in April. And she said, but Dr. LaFall, I'm coming up next month with my son, his wife, and my grandson. I'll be happy to talk with you then. So if I can jump to that, that lets you know what happened then. She said, we only ran one room on Saturday. And I had a patient on the table. I was getting ready to give my patient some Pentothal. And then I was going to put in a tube for the operation we were going to do. They called from downstairs and said, there's been a very bad accident out by Haw River. They're bringing in some patients. One of them is critically injured. And she said, I am so glad I hadn't given my patient on the operating room table some Pentothal, because I could not leave a patient whose life I have placed in jeopardy by giving him some Pentothal, something that decreases respirations, and go to a patient whose life is in jeopardy. But I hadn't given anything. So she said, I put my endotracheal tube and my laryngoscope in my pocket. I ran downstairs. And when Dr. Drew came in, I was downstairs waiting along with other people who were there. She described this to me. She said that his pupils were dilated, both. There was blood coming from his ears. He had a crush wound of his chest and an avulsion wound of his thigh. And she said he was breathing in a very shallow manner, very shallow. And she said he was in deep shock and his blood pressure was in the low numbers. And she thought it was in the range of the 60s. And I'm going to mention something about his record in a moment. So she said then what she did, she got an endotracheal tube, the laryngoscope, put the endotracheal tube in, and she said, Dr. LaFall, we were all sitting down, she said, I, not a bragging eye, not a bragging eye, but a sincere, thoughtful, genuine eye. She said, I was with him from the time he arrived until the time he died. I put the endotracheal tube in. I gave him IV fluids. Not that I was the only one there. Other people were there too, but we cared genuinely about him. And we were thinking about transferring him to Duke, only because Duke is a university. Alamance General Hospital is a little hospital. But we didn't have the time to get him there. His condition did not allow us to transfer him to Duke. I then asked her, did he get any plasma or blood? And she said he did receive plasma, but they didn't have blood then. She said, Dr. Falk, we were a little hospital. We didn't have blood at that time. And by the time blood was available, he was dead.
Many people think that the classic work by Spencer Love explains why that myth has persisted for decades. She speaks of Alpheus Mabry down below Dr. Drew's photo there, a 24-year-old vet who was driving also in North Carolina, had a single car crash, a head injury, taken to Alamance County Hospital. They tried to transfer him to Duke, but Duke's 12 Negro beds were filled. He went to a smaller hospital in Durham and he died. And there are people that think that the story of the internationally known Charles Drew got merged with the little known story of Alpheus Mabry. And so the myth persisted despite Dr. LaFall himself, that's Charlene Drew Jarvis, Dr. Organ in a presidential address, his friend Montague Cobb, who was the editor-in-chief of the Journal of the National Medical Association for decades. All of his friends and colleagues were the ones that tried to set the record straight. We honor him on the face page of the Society of Black Academic Surgeons, as we do Asa Yancey with the Asa Yancey Lecture. This is the inaugural meeting, 1989. I was still in training. This is my colleague Dave Jacobs. There's Dr. Stain, Steve Stain, Dr. Organ and his son Brian, and there's Dr. Yancey. Dr. Organ right there, Eddie Hoover. You all know that Dr. Sapistan and Anya Aquari hosted it, Raul Hanlon. This Haile DeBas, this photo grows more precious to me with each passing year. 30 surgeons. This woman is Dr. Quarry's cousin. No women, no women. When I show you a photo from the 2000, and University of Washington hosted it in 2009, thank you very much, last time that I was out there. And it's taken a generation. The next photo that I have in 2016 at Ohio State, 143 surgeons, 47% women. So we have a long way to go. In 1989, 31 years, a very different look of American surgeons. So I conclude that Dr. Drew's impact go beyond just that of his abbreviated life. I'm inspired by him, and he died long before I was born. it can be traced through his colleagues who insist that ethics of surgery should be guided by the principle of compassion and integrity, even when inconvenient and not supported by popular myth, as told by his former student, his former intern, and his former resident. And with that, I just can't tell you what an honor it's been to have the opportunity to discuss it at this symposium, particularly in light of some of the prior presentations. Thank you very much.
Well, Dr. Cornwell, thank you. I saw one of the comments that of one of our aficionados of history lectures that this is the best one that they've ever heard. So that's a pretty good accolade. I don't think it's hyperbole here. It's a really meaningful story, and thank you for going through that history with us of a really remarkable individual, and in a sense, I guess the grandfather in terms of mentorship to yourself.
Right.
Thinking through the your relationship with Dr. Lafall and now your chairmanship at Howard.
Yes.
And I also just want to acknowledge the other talks in this session. We felt that this was really an important discussion to have, and I just want to acknowledge these are challenging conversations, and I actually appreciate the challenges that the other speakers gave. And when it makes me feel uncomfortable, I have to acknowledge it makes me feel uncomfortable, and that's a place where we can grow and change. Just before we take a break, I just think this is a good moment to let our faculty and residents and staff know that we've created a new endowment in the Department of Surgery. And the seed money for that endowment is from a very generous gift from Dr. Jorge Reyes. But we've wanted to create an endowment that specifically supports the diversity, equity, and inclusion activities of the department. We have a couple of endowments that do that, but we wanted one that allows flexibility of me and the Diversity Council to support the medical students, the residents, and other initiatives in diversity, equity, and inclusion. And the name of it is the UW Medicine Surgery Endowment for Diversity, Equity, and Inclusion. Nothing complicated. And I am going to be sending information out to all of the members of the department about that later. But I wanted to announce that because I think it's really important. This is just one of many action items that we have to try to make a difference. And I also just want to take the moment to thank Dr. Reyes for the very generous contribution to get this endowment started. So with that said, Dr. Wu, I'll turn it over to you to tell us about the break and when we'll be restarting.
Yes, we'll start at 11:20. So that'll give us 11 minutes for a break. And so everyone return and we'll start promptly. Thanks again.
Thank you.
Speakers and to Dr. Cornwell. Thanks.
Thank you.
Welcome back, everyone. I hope everyone had a chance to enjoy their short break. The next session, I'm going to feature a variety of faculty members from the remaining divisions in our department. First being Dr. Jonathan Sham, who's one of our previous trainees who we were fortunate to recruit back to the University of Washington after recently completing the hepatobiliary tract complex surgical oncology fellowship at Johns Hopkins. He's going to speak about the role of surgery in locally advanced pancreatic cancer. Next, Dr. Edgar Figueredo, who is my colleague at the VA and is the leader of simulation in healthcare at the VA. And he's going to speak about the current status of robotic hernia repairs. And then in this section, Dr. Ken Gao, He is a pediatric surgeon and medical director of the Vascular Access Service at Seattle Children's. And nationally, he's the surgery representative on the executive committee of the American Academy of Pediatrics. And he's going to speak about access of care for children needing surgery. So, Dr. Sham.
Good morning, almost afternoon. Thanks so much for having me. Again, my name is Jonathan Sham, and I am one of the hepatobiliary surgeons here at the UW, and I'll be just chatting today a little bit about the role of surgery and how it's evolving in locally advanced pancreatic cancer. Next slide. No disclosures for me. So as we all know, pancreas cancer, it's not a good one. We get excited in the field when our 5-year survival rate reaches 10%. But there is a lot of room to grow, both on the surgery side, but also on the chemotherapy side. Next slide. And we are making some headway. So, back when I was in residency, we were always taught about the CONCO-1 trial in 2013, which, state of the art at that time was after surgery and best available chemotherapy. We were talking about 5-year survivals in the 20% range. Now, fast forward to 2019, and you have the PROTEGE 24 trial that just came out, which showed a really remarkable increase using multimodal chemotherapy, in this case, modified FOLFIRINOX, in overall survival, somewhere in the almost 50% range. And so, obviously, we're doing a better job at controlling disease, not only locally, but systemically as well, which then improves long-term survival. Next slide. And this change has really manifested itself in the national guidelines. Here are the national guidelines from 2017 from the NCCN, and this is the locally advanced page. And it's a little jumbled, and since I don't have a pointer, I'll just, if you look on the left side, if you have a patient who has good performance status in 2017, first line is going to be chemotherapy. Then if they still look good, the next step is again chemotherapy. And if they still look good after that, next slide, we're left with essentially clinical trial, which is the NCCN guidelines way of saying, we really don't know what to do. Next slide. Now, fast forward to 2020, and again, this is the exact same page from locally advanced algorithm. And again, you have good performance status. First step is chemotherapy. And, again, we need to test the biology of this disease. We need to make sure that, we're going to have disease that's going to respond to systemic therapy. But then if they still look good after their neoadjuvant chemotherapy, next slide, we now have new options. And top of the list here, consider resection if feasible. And this is in stark contrast to, again, just that clinical trial option that was available only 3 years ago. Next slide, please. And while this is just a clinical talk, I will just touch briefly upon published data in this area. And this is a series out of Johns Hopkins, which is the largest locally advanced series to date that's been published. Next slide. Essentially shows their experience in their multidisciplinary clinic. You can see there in the locally advanced group, there are almost 500 patients over a 4-year period, which had locally advanced disease. And over the course of time, if you look in the bottom left, about 20%, so 1 in 5 made it to resection. So by no means are the majority of patients getting surgery. However, in appropriately selected patients, we are able to offer surgery in a safe manner. So next slide. And so if you look here at just their preliminary outcomes, it's really an impressive 89% R0 resection rate. I mean, that's really remarkable given these are locally advanced patients. 6% complete pathologic response rate and a mortality of only 1%. And then at the end of the day, again, at the time of this analysis, a really respectable 35-month overall survival. Next slide. And what enables us to offer surgery to these patients? Well, it's really an evolution in understanding of both imaging, but also surgical technique. And so I pointed out this CT scan here of a patient. And if you have this CT scan at presentation, and that arrow is pointing to the tumor touching the SMA, if you have this CT scan at presentation, there's tumor there. There's tumor on blood vessel. And if you went in for surgery right now, you're going to leave cancer behind, no question. But the interesting thing is after chemotherapy, after 6 months of FOLFIRINOX, if you have the exact same CT scan, we actually don't know what that means. This could be just desmoplastic stroma. This could be scar. We're not sure whether or not if you cut right there by the artery, whether or not there's going to be tumor there or not. And that's really evidenced by that 89% R0 margin status rate that I just pointed out before. And so having this understanding that, well, we don't really know what this is, as long as all the other markers are looking good, dropping the CA19-9, good performance status, it really does justify a more aggressive surgical approach. And that really brings me to the point of the next panel on the right there. Oh, go back one, if you don't mind. On the right side there, you have one of these classic low uncinate tumors or head tumors involving all the tributaries of the SMV, which again is technically unresectable by NCCN guidelines. Well, we know, again, if there are good collaterals, particularly on the left side, that you can preserve during surgery, you can get away with just dividing the tributaries, dividing the portal vein, and not reconstructing. And so there are series showing actually really reasonable survival after non-reconstruction of the portal vein. We've actually done this here at the University of Washington with pretty good results as well. Next slide. And kind of a procedure that really highlights this pushing of surgical dogma is what's called the modified Appleby procedure. And the Appleby procedure is actually a procedure that was developed by a Canadian surgeon, Lyon Appleby, back in the 50s for locally advanced gastric cancer. And essentially these were cancers that were eroding through the posterior wall of the stomach, into the pancreas, into the celiac, and it necessitated really aggressive surgery to get it all out. Now this surgery actually fell to the wayside, understandably, because at the time they didn't have good systemic control of the disease, but really come back and the pancreas surgeons have modified this to essentially just include distal pancreatectomy, splenectomy, and celiac axis resection for the management of locally advanced tumors. And so essentially what you do is, and I don't have a point here, but essentially you ligate the celiac at its origin, and then ligate and divide the distal common hepatic artery. And so then perfusion to the liver and stomach is reliant upon tributaries from the SMA going around the pancreatic head in the inferior pancreatic or duodenal to then perfuse the stomach and liver. And again, on the right panel there, you can see kind of post-resection, the stub of the celiac, and then the stub of the distal common hepatic artery. Next slide. And so here's a patient we evaluated in our clinic recently for an Appleby, and you can see there on the left panel, the yellow arrow, again, the artery, that's the celiac artery, encased by tumor. And this really neat 3D recon I had Eric Soloff make up for us essentially shows an impressive collateral between the SMA and the GDA. And so when you see this, you're feeling pretty good that afterwards you're going to have good perfusion to the liver and stomach. Next slide. But the converse is also, it also happens. So this is another patient, same thing, encasement of the celiac artery on the left side there. But then when you do the 3D recon, there's really no definitive collateral between the SMA and the celiac. And you're getting a little nervous, certainly, when you see this, but intraoperatively, we'll do test clamping of the distal common hepatic artery. And, you always kind of hold your breath a little bit, but, it almost never fails that after you clamp that, you wait 4 or 5 cardiac cycles, put the ultrasound on the proper hepatic and the right gastroplug artery, and you start to see flow coming back, and things pink up, and actually, most of the time, their liver numbers don't even bump. And actually, next slide, that's actually exactly what happened with that particular patient. That CT scan was of the Mr. John Navoy, who was the first patient to undergo a modified Appleby procedure at the University of Washington. That's him right there in the middle between Dr. Kovler and myself. He was diagnosed in September, underwent neoadjuvant modified FOLFIRINOX, and then got surgery in February. Now he's 8 or so months after surgery with no evidence of disease. Next slide. And so again, I just want to give a brief shout out to my partners in the section of HPB surgery, but particularly my partners in the pancreas program, Dr. Pilar-Setti and Dr. Park. Your experience and support has really led to a lot of growth for me personally, but also I think growth for the program as a whole, and to what I think is really the premier pancreas program in the region now. Next slide. So just brief take-home points. First and foremost, biology is king, right? If you're going to have a tumor that progresses on chemotherapy, no level of systemic therapy or a surgery is going to lead to a good outcome for that patient. And so it's really about selecting the right patients for aggressive surgical therapies. this isn't what you might think, but better systemic therapies actually mean more surgery, not less. If we get better control, until the day that we have a pill that you can take to just eliminate all pancreas cancer, which again is a long way off as the way things are looking now, actually there's going to be more patients that just have an indolent tumor that gets kept at bay with chemotherapy that really justifies, again, a more aggressive surgical approach in those patients. Understand that, what you see is not necessarily what you get with post-chemotherapy imaging, and that soft tissue by the SMA may or may not be tumor after 6 months of FOLFIRINOX, and understanding, again, what you can and cannot do in a locally advanced patient. And then also, it is okay in appropriately selected patients to challenge some of those surgical dogmas where, not reconstructing the portal vein or resecting the celiac axis may not be so crazy after all. So thanks so much for your attention, and I'll get back to Dr. Wu.
Dr. Figueredo.
Good morning. Thank you. I didn't have any conflicts of interest. We're gonna talk about robotic inguinal hernia. I am totally in agreement with Dr. Warren when he wrote just 1 month ago an editorial about the role of robotics in inguinal hernia repair. It's wonderful technology, but there's a lot of criticism, and mainly it's because of widespread adoption without clear evidence supporting its use, and particularly because it's very costly. Next. So what is going to happen when you start doing robotic inguinal hernias? And this is basically my path. I took as a model what my colleagues at the Northwest Hospital were doing at that point. So know your patient, see what are going to be the best cons and pros. I'm going to go laparoscopic TEP inguinal hernia repair for a bilateral small hernia, or I'm going to go robotically because it's going to be really easy for me to start and for the residents also to start their training. Know yourself, what are your skills, and you need to be very patient if you want to be a robotic or a laparoscopic surgeon. Know well your equipment, your team. The scrub techs are going to really, really help you, and they actually are going to become very helpful also for the residents, because then the residents don't have to be all the time at the bedside, but they can go to my second consult that actually I'm very lucky to have at the VA. Review the chart, the images, possible problems, and don't be afraid of postpone the case, convert to lab or to open, or call for help to any of your other colleagues. Next. What are the disadvantages? So really all these disadvantages have been solved. No haptics, this is solved with anesthesia. When I am with my eyes open and seeing a 3D view, I can actually feel that there's some resistance and some tissues that are harder than the other ones. The bedside system problem is solved with good scrub techs, as I said. The extra ports could be solved with hammock sutures, with magnetic devices, or just with an extra port. Laparoscopic port would be totally fine. And the adequate instruments these days, the technology from the Da Vinci is actually better than the laparoscopic one. Now, the learning curve, this is much, much easier. And I don't agree these days that you need to be a really good laparoscopic surgeon to be converted into a robotic surgeon. As a matter of fact, most of the programs these days, the people actually are more proficient being robotically than laparoscopically. Next. This is a slide from my esteemed colleague, Dr. Andy Wright. What is the value? It's results divided by cost. But to whom? To the patient? These days, there is some benefit to the patient, but pretty much equal to laparoscopic. To the hospital, maybe in terms of marketing. To the insurance company, maybe not because of the cost. To the health system, probably because the cost and the outcomes. Next. And for the surgeon, it's good for ergonomics. This is what happened to me. 3 years ago, I saw some of my colleagues actually having problems with their elbows, having tennis elbows without playing tennis, but just because of the laparoscopic burden in their elbows. So I decided to go and start training on robotic before I became like one of them. Marketing and reimbursement, definitely big value, especially in the private sector. Next. So these are the statistics. In 2015, a robotic inguinal hernia repair in the United States was performed 6% of the time, laparoscopic 29 and open 65. 2 years ago, that increased to 20% robotically, laparoscopic 20 and open came back to 60. They don't have the statistics right now for 2020 that will be published in a couple of months, but they are expecting that the robotic inguinal hernia repair increased to 25 to 30%, going down with from the open repair to around 50 to 55%. Next. So this is a comparison with cars. A lot of people like cars. I'm in between. Next. So this is what I had for the first time. It was a DaVinci SI, and I had dual console. It was great because I could really help I was in one console, I'm a resident in the other one, and I was able to really help them. Next. And then I was upgraded. I think that Dr. Tatum and Dr. Landau thought that I was actually behaving. It's hard to believe. And then they actually helped me, and we acquired DaVinci Xi, that is the top of technology these days. Next. Now, all these robots, the patent actually expired for the DaVinci. So all these robotic companies started going into the market, and this is going to be great because some of them actually have haptics. Some of them actually you can move the camera just by moving your head. So, and the price is going to go down. Really interesting. We will see what they are going to bring us to in these days. Next. Benefits, another slide from Dr. Andy Wright. The main benefits for me are the education and the ergonomics. Education for my residents, as I said, the second console is invaluable. Ergonomics, it's really good for me. It's been working great. I don't have any pain. I don't complain of any pain, headaches, or back pain. As some other surgeons actually were complaining in the rival trial. There was a trial comparing robotic versus laparoscopic TAP inguinal hernia repair. Of course, the cool factor and the marketing, it's in play. Next. I remember one of my residents actually doing, she's going actually for trauma fellowship these days, but she did her first colectomy in the robot. I remember when we just put the ports, and I told her, okay, go to the console, and she asked me to do what? And I was, well, you're a surgeon, you signed for this, so go and operate. I'll help you with the other console. The case went really well. Next. So, know your patient. Am I going to operate a bilateral small direct inguinal hernia with an easy lab, total extraperitoneal, or am I going to go with an easy robotic one? Of course, if I don't start doing easy cases and I don't train myself, I'm not going to be able to go and do the large inguinal hernias that I'm started actually doing when I acquired the robot. Next. I'm going to take, we didn't have time actually for videos, but I'm going to show some really key slides with pictures here. This is what we saw in the pelvis from inside, transabdominal preperitoneal approach. Medial, we have well, I don't think that I have control over the pointer, but medial, you're going to see Cooper's ligament, and then you're going to see two compartments. The one to the left of the screen, close to the Cooper, is the parietal compartment, divided by what we call the intermediate fascia, and lateral is the visceral compartment. Really important because we cannot dissect the fat just at the same level in both compartments. It's really going to be important to respect the nurse protection with this layer, and also where we're going to place the mesh. Next. This is the case of a direct inguinal hernia. We are reducing really easy in a laparoscopic one. Most of the time when we are created the preperitoneum, it got reduced by itself. And then we're going to go and we're going to observe the defect in the anterior abdominal wall. Some of the people actually are stitching these defects. I don't agree with this because it's still going to be under tension. So I don't know why we went from no tension surgery to creating again tension surgery just because we can, and we can now stitch up with the robot. Next. For an indirect inguinal hernia, we go medial. You can see actually the divot in between the two tools. That is the defect in the deep ring. And in the picture in the right, you can see actually that I mark what I'm pulling is the vessels, and you can see with the yellow dotted line the vas deferens. So this is what we're gonna achieve. We're gonna find the vas deferens. We're gonna find the vessels, and then we're gonna go and do our finishing reducing the hernia. Next. So I'm pulling from the hernia sac, and we're doing something called a no-touch technique. Really hard to do the no-touch technique, meaning I'm not going to grab the vessels or the vas deferens when you are doing it laparoscopically, basically because you get tired of pulling and pulling, especially in these very large inguinal hernias. And you can see that the only thing that I'm going to need to do is just apply some pressure, pull on the hernia sac, and then I can actually cut using the scissors. Next. These are the 10 steps for the critical view of the section of the myopectineal orifice. This was developed by my Colombian friend, Dr. Jorge Daes, and also by Ed Felix here in the United States. So basically it says that we need to dissect 2 centimeters across the midline, dissect 2 centimeters posterior to the Cooper's ligament, parietalize the vas and the spermatic vessels, observe the iliac vein and artery, dissect any peritoneum between the vas and the spermatic vessels, so we're not going to leave any peritoneum that will recur immediately after finishing the case. Display the direct hernia space, displace femoral and indirect hernia space, reduce all cord lipomas, do enough posterior lateral dissection, and use a minimum mesh size of 10 by 15 centimeters with wide overlap of the myopectineal orifice. I have to say that my colleagues, Dr. Tatum Marquardt and I, we do not agree with the size of the mesh. We use a 3D size mesh that is 8.5 by 14 centimeters. When we use the large, is around 10 by 16, and it's very cumbersome to put it there. Next. So this is going to be the mesh placement. The fixation actually can be done with several ways. One is nothing, especially the ones that are Velcro, and those are the ones that the University of Washington Hospital has. With sutures, with tags, or with glue. I usually use tags, and the reason is I can put 2 tags and speed on the surgical time, and then put 1 tag to close the peritoneum, and then my residents actually are going to have a much easier way learning how to suture inside that peritoneum. Next. So what is good for me is really good when I have a really large direct or indirect inguinal hernias. I'm not going to be too tired. It's not an easy case for sure. And but I can actually then reduce this pseudosac, and I can actually bring it back. Most of the time I don't do this for the regular indirect or direct inguinal hernias, but I like to do it laparoscopically. I can do it in the indirect fashion, but I cannot do it the direct. It's really hard to go up and bring that pseudosac that is actually the transversalis fascia down to the Cooper and fix it. The theory is that you can reduce the incidence of seromas, but so far nothing is proven reducing seromas. Sometimes we need to put drains. Next. This is an inguinal hernia, and this is one of my patients actually that it came, and he actually had an anterior approach, he had a laparoscopic approach, he had a mesh, and I was my job was actually to go and fix this hernia for the 3rd time, and it was large, but it was successful with the help of the robot. Next. These ones are really cool. The obturator canal and hernia, you can see the fantastic 3D view of the obturator canal with the nerve, the artery, and the vein. And then we are dissecting into the reduced space in order to achieve reduction of a hernia that is in the right picture. And then we're going to put it, now I'm going to place a really large mesh to cover that defect. Also, it's really noticeable that when we are doing this, we can actually leave more fat on top of this structure. So very few cases that you're going to have pain associated to mesh placement preperitoneally, just like the laparoscopic way. Next. Well, when you do a prior mesh open or laparoscopic approach, the mesh in the left, they dissect not in the right space the parietal component. I couldn't actually remove that mesh. Most of the time, this is what happens. We cannot, the mesh is attached to the vessels. This patient was having some problems with pain. The other one was a recurrent hernia, and this one was attached to the visceral compartment. So it was actually really easy for me to bring down the mesh with fat and the peritoneum and place another mesh. Next. For prostatectomies, you can see here using Firefly technology, ICG, just minutes after the injection of a small dose of ICG, I can actually see the structures. In the left, you can see the vessels. In the right, you can see the vas deferens arching. And in the middle is just fibrotic tissue. This is a recurrent ×2 anterior and laparoscopic operation, and the patient had an open prostatectomy. Next. So less pain, less narcotics. We know about this thing. There are fewer narcotics for robotic than left inguinal hernia. That was a study published in Hernia in 2020, but the randomized multi-center control trial didn't show any difference in complications, readmissions, pain, physical activity, or cosmesis. That was the rival trial published in JAMA Search in 2020. Next. So in conclusions, more surgeons are adopting a robotic inguinal hernia repair versus laparoscopic or open. For sure, there's much better visualization and more accurate dissection. Despite the cost, there's better value in reoperation and prolonged operations. There are definitely better ergonomics for the surgeon, and I'm totally sure that if the cost decreases, it will definitely increases the value of this procedure. Thank you very much. Back to you, Dr. Wu.
Good morning, everyone. I'm pleased to have this opportunity in order to speak with you this morning. The morning has been really great, and a lot of what I'm going to talk about has threads to what has already been talked about earlier today. Specifically, the divide that I'm talking about refers to the challenges with families who are living in the rural areas and are disadvantaged. The disparities are issues which have been going on for many, many years. And my goal today is to talk on pediatric surgeons and how we can deliver better pediatric surgical care to Washington State. Next slide. So I have no disclosures with the exception that I've been traveling to Central Washington to do outreach for the last decade. And in fact, I'm actually presenting from our Tri-Cities clinic today. Our goal today is in order to identify 3 categories of barriers to access to surgical care, describe some of the examples of what these barriers are, discuss how an individual and an institution can improve delivery of care, then finally, how you can apply this to your practice to help patients that need your care. So I'm going to talk about a young lady, 15 years of age, who I saw a few years ago, who had a 2-year history of a mole on the medial aspect of her left knee. It became painful and began to bleed. A punch biopsy that was done by her dermatologist demonstrated a spitzoid melanoma with a Breslau depth of 3 millimeters. She was referred to us for further therapy and management. I'll stop there and say, we're actually going to take a slight swerve here and not really talk too much in terms of the surgical treatment of this patient. Next slide. We'll talk about what we will talk about, which are the barriers that this patient and her family have in terms of receiving pediatric surgical care. We divide things into 3 main categories: physical barriers, financial barriers, and cultural barriers. And we're going to speak about each of them specifically for this patient so you can get an idea as to the challenges that Latino families have in Central Washington who need surgical care. So in terms of the physical barriers this family have, they live in Walla Walla. On this map, you can see where Walla Walla is located. It's located in eastern Washington. In order to drive to Seattle and return, it requires at least an 8-hour round-trip drive. Furthermore, it's 544 miles. For those who drive a lot, that's still a fair amount of distance to drive. And on a regular day, you still need to go through at least one pass. During the winter times, this can be a challenge. Winter driving through the passes can be really treacherous. Furthermore, there are often closures during the winter and during other times of the year for road construction and sometimes problems with the road. This, of course, always requires someone to drive, and the assumption is someone in the family or their relatives will be able to drive for them. These are huge assumptions. Next. So how do you conquer these physical barriers? Well, as I mentioned, I am currently in our outreach clinic in Tri-Cities. This has reduced their 8-hour turnaround to a much shorter time. It's 58 miles from Walla Walla and is a 1-hour drive from their hometown. We also have mechanisms in our hospital in order to help families in order to assist with their transportation. And if there's any silver lining with COVID, you know that telehealth is something that has really helped us. It helps us, it helps the families. And we've leveraged telehealth as much as we can in order to help families who live far away. Further, what we've tried to do is really minimize in-person visits that require the child and the family in order to make long drives. Lastly, we've worked with PCPs in their own communities in order to try to maximize how many things that need to be done, have them done as close to home as possible, and utilize the expertise of the PCPs. Now we'll talk a little bit about the financial barriers. This family has limited resources. In terms of looking at other families who live in Central Washington, this is not unusual. A lot of the families that live in Central Washington have much lower overall take-home incomes than those that live on the west part of Washington state. Many people in Central Washington are undocumented workers, and this puts a specific challenge to families because even despite the ACA Affordable Care Act, those families still do not have access to healthcare insurance. This is a huge barrier because families that don't have healthcare insurance do worse. Lastly, limited education really challenges families because they are unable to understand sometimes what is necessary, not only in what their child needs, but also in how to take care of their child afterwards. So how do we conquer these financial barriers? Well, Seattle Children's is really focused on Central Washington and supporting the families to get the care that they need. Our social workers are really attuned to those children that live in Central Washington. They have a focus in order to try to get them the care they need and help with looking at housing and money in order to make sure that they have food and transportation. I think as people who are really invested in the care of our patients, we need to be very careful about who we choose as our future leaders because they are the ones that will dictate the ultimate things that will happen at a national and local level in order to figure out what we can actually do. Healthcare advocacy is something that we all are that we can help do and support. We also need to, as talked about earlier, look at the entire pipeline of the future leaders, specifically physicians, surgeons that may be able to care for families in the future. The third barrier is that of cultural barriers. And we know that Latinos are a very diverse and growing group. Clearly, their choice of language has been Spanish, and this poses a language barrier for those, such as myself, who do not speak Spanish. Many of them are new to the culture. Many have moved recently to the United States, and the entire culture that they've been presented with is very unusual for them. Furthermore, and not necessarily a barrier, but something that we have to work with, is a very deep religious belief that a lot of Latino families have. Lastly, because of all the challenges that they have had, many of them distrust our system. So how do we address these barriers? Well, this is certainly a talk that could be in an hour itself, and I'm certainly no expert in the Latino culture. However, having worked with many families in Central Washington, the 4 things that we need to really focus on and be respectful of is that of making sure that we understand the fact that they are really family-based. There must be mutual respect. We must understand the hierarchy of the family and really understand the religious ties that the families have. Key really is obviously to use interpreters. Since I don't speak Spanish, we need to make sure that we have the Spanish speakers, whether it be in person or over the phone or on video, in order to make sure that what is spoken about is truly understood. The other thing that we in the Tri-Cities Clinic have done is hire Latinos, people that they can look at and see and understand, and look like them. Cultural training is also important, something that I think is really invaluable in order to understand what the issues are. And as mentioned earlier, I think we need to grow the pipeline in all the people throughout in order to make sure that medical students and residents and fellows are ones that will end up being the faces that are similar to the ones that the families can look at. So as a summary of what we've done with Ruth, we have in her treatment, we did our initial assessment in the Tri-Cities Clinic. We had Spanish-speaking staff who were able to help her and her family. We established rapport with the family, and it took some time in order to answer all the questions. With, as mentioned, our social workers through our community, health, and engagement, we were able to find transport for them, as well as financial assistance for travel to Seattle for her surgery. All of her subsequent follow-ups have been done closer to home. Ultrasounds were done in wall-to-wall and were sent electronically. And during the pandemic, we leveraged telehealth in order to be able to see her from her home and go through the follow-ups of her ultrasounds. She's done great, and she's only had one visit to Seattle, that being her surgery. All the rest have been done very close to home, and I think represents a really nice reflection of what we can do as a system in order to support families. So here are the actionable items I can imagine as you as an individual, as a surgeon, and us as an institution. From an individual standpoint, I think it's important to know where families live, understand the social determinants of health that they may be going through. Now and in the future, we can leverage telehealth in order to reduce travel times for patients and families. And really be selective. Select only the inpatient visit or in-person visits that are necessary, and partner with your local physicians. From an institution standpoint, social work is really key here. They help make the arrangement for families, and this is a key move here. Telehealth, from an institutional standpoint, they need to invest, leverage, and advocate for continued access. Lastly, advocacy at a state and federal level to support healthcare funding is really critical. And the last 2 points I'll point to is having an outreach clinic and then doing surgery, if possible, closer to home will really make things easier. And lastly, I'd like to thank all of my colleagues for allowing me to go out to Central Washington in order to be able to look after patients, and thereby they would look after my patients while back in Seattle. And so there's a lot of coordination of care. There's got to be a lot of partnership and teamwork involved here. So as a summary, over the last 10 years of outreach in Tri-Cities, I would say that I've seen almost 2,000 patients in the Tri-Cities Clinic. I've operated almost 300 patients in a Tri-Cities. In total, if I were to add up how much things that has hopefully benefited families, it represents almost 1,000 days of work that parents don't need to take off for clinic visits and surgery. Almost represents over 1,000 days of school saved for children. And for those families that need to travel into Seattle, oftentimes because of the travel time and the distance and the time that they finish with the visit, many of them end up choosing to stay extra days in a hotel in order to be able to minimize the travel time at nighttime. And I think we've helped with almost over 100 hotel days that have been avoided. This is not to pipe or trumpet my own accomplishments, but to say that one person can do a lot. If a lot more people do things, there's even more things we can all do as a team. Thank you very much.
Thanks, Ken. A few questions. I'll direct to Ken. With your early adoption of telehealth, especially in specialty care, have you experienced any pitfalls? And do you think there are opportunities to actually telementor, say, community general surgeons and rural surgeons to, as far as expanding their skill set and to help co-manage pediatric patients?
Thanks, Peter. That's a great question. So in regards to telehealth, fortunately, Seattle Children's was very early on in adopting telehealth and trying to incorporate that during the pandemic. And I would say that obviously there's been some growing pains in trying to figure out which patients would benefit from telehealth. I think we've all had to work through that. I would say well over half of the patients that we can see on telehealth and do a lot of the care by telehealth. In terms of collaborating with local surgeons, we haven't had that next move yet. I think that's a great idea and something that we can focus on in the future, but thus far we have not gone there yet.
Great. For Jonathan, considering your increasing role of neoadjuvant approaches compared to upfront surgery, which we did more of in the past, what do you think is the optimal way to manage jaundice in patients with potentially resectable disease? Since these periods of patients are now undergoing pretty extended periods of waiting before they undergo surgery. And secondly, how does patient frailty impact your treatment decision making?
Thanks, Peter. It's a great question. You know, for any patient who we anticipate is going to need a neoadjuvant treatment course, and so that's any locally advanced patient, we do prefer a self-expanding bare metal stent for management of the biliary tree. Outcomes are really quite good, a 90 to 95% patency over the course of treatment, and if something does happen, they can just be addressed endoscopically. And we really try to, to get away from the plastic stent unless we're going straight to surgery, which again is a smaller and smaller proportion of patients. As far as the frailty question, there are several frailty indices that people use. Our group and the NCCN advocates for use of the ECOG performance status. And so essentially ECOG 0 and 1 is a green light for surgery. And for select ECOG 2, we'll take them. But again, that affects not only surgery, but their ability to get chemotherapy as well. And so there's some prehab programs, nutrition, pain control, pain management, and those all kind of go into the multidisciplinary approach to enable us to get these patients to definitive therapy.
Very difficult disease and difficult patients to treat. Edgar, with your robotic approaches now, you did mention about prostatectomy, but do you believe overall with your robotic, with improving technology, do you think it expands the minimally invasive option for patients that traditionally aren't candidates for standard laparoscopic approach, say in patients that routinely have undergone, say, urologic procedures such as prostatectomy?
Yes, in the pictures that I showed, actually, those were from patients that I operated at the VA. They had prostatectomies before. One thing is that when they do actually an open prostatectomy, the preperitoneal plane is somehow better preserved than when they do a laparoscopic or robotic prostatectomy. And the reason is that they actually are going to bring down the peritoneum and they're going to drop the bladder, and they do not put that plane back up again. So that's one of the things. And when you do those, of course, going with the robot and doing this dissection is much, much easier. But it can happen also the opposite. I remember a case that this is what I had. It was a patient had laparoscopic prostatectomy, and he had already a colon resection. And I went and put the robot there, and after 10 minutes, I realized really, really fast that I wouldn't been able to bring down the bladder or release all the adhesions and the intestines that were around. So I actually retrieved the robotic pores and did a laparoscopic tap. Instead of 3 incisions, I made 6, 3 on each side, but converting to laparoscopic helped me. So this is one of the points when they're saying, well, if you want to be a robotic, you need to be also laparoscopic. These were the very special cases. I don't think that is all the time, but definitely the robotic technology is helping us a lot, especially with these inguinal big hernias that we are seeing, and patients had 1 or 2 operations. So really good that we can go and then offer this technology to our patients.
Great. Well, thanks to all 3 of you for giving those great talks.
Thank you.
For our next, for our last session, I'll introduce our 3 next speakers. Dr. Bergfield, unfortunately, regrettably, he can't give the lecture live, but he was able to give us a recorded lecture. He's the Director of Craniofacial Surgery Fellowship Program in the Division of Plastic Surgery, and he's going to give us a recorded lecture on the facial trauma reconstruction. That'll be followed by Dr. John Rollo, who's a vascular surgeon with expertise in minimally invasive endovascular procedures, and is going to give us some interesting and fascinating results of the new limb preservation service. And then we'll conclude with Dr. Chris Burke, who's going to, he's the Associate Program Director of the Cardiothoracic Surgery Residency Program and Co-Director of the Thoracic Aorta Program. And he's going to give us a talk on aortic valve preservation surgery. So can we, Ellison, can we start with Dr. Bergfield's?
Good morning. My name is Craig Bergfeld, and I'm one of the craniofacial plastic surgeons here at Harborview and at Seattle Children's Hospital. And I'd like to speak with you today about panfacial fractures. This is an image demonstrating what I mean by panfacial fractures. These are some of the most challenging cases that we as craniofacial surgeons do, and we do quite a lot of them at Harborview. These are generally the result of high energy events such as high-speed MVAs, fall or jumps from greater than 3 or 4 stories, severe crush injuries, or close-range gunshot wounds, such as the self-inflicted shotgun wound demonstrated here. Now, when these patients get to the trauma bay, it's important not to get distracted. Even the most expert and seasoned nurse or physician can get distracted by these horrible facial injuries, but you need to remember your ATLS protocol. And nothing more important, obviously, than the airway. You can just imagine how difficult it can be to get an airway in an injury such as this, so you may need to consider tracheostomy. Also remember the C-spine. We know that 10% of facial fractures have concomitant C-spine injuries, and these are certainly no different. We're good at Harborview about considering carotid dissections, especially in high-speed deceleration injuries, but it's something to keep in mind. Now, you might be tempted to go straight to the operating room, but I think it's important not to rush with these cases. Patients have often lost a lot of blood in the field, so they should be stabilized in the ICU and their hemodynamics normalized. It's also a good idea to consider placing a tracheostomy and possibly a G-tube in preparation for your surgery. Now, I'm a firm believer that these cases should be done at a trauma center. You know, they're hard for me to do, and I have a fellow, a couple residents, a medical student, all there helping me. I can't imagine doing a case like this by myself with just a scrub tech in a community hospital somewhere. And that's because the multiple layers of fractures don't just multiply the difficulty, they make it exponentially more difficult. You think you have a fracture reduced on one part of the face just to find that it's been displaced on the other side of the face. But don't get too caught up in the exact fracture reduction. Remember the basics. You want to set the facial width, set the facial projection, restore orbital volume, give the patient a functional occlusion, and hopefully a normal appearance. And to do this, we work from known, which is stable, to what's unknown or unstable. And prepare your team for these surgeries, and that means make sure you obviously have the adequate amount of imaging. 3-dimensional reconstructions of your CT scans can be really helpful. And you may consider making a model such as the one shown here to help you prepare your surgery and plan. Sometimes we'll take impressions and make an occlusal splint to help us guide our occlusion. And these are the kind of surgeries you want to get all hands on deck for. So if you have a free resident who's on a slow rotation somewhere else, see if they're interested in coming over and helping out. Ideally, these surgeries are done when you're working with your A team. And your A team are the scrub techs and nurses that work with you on a day-to-day basis. They know you, they know your instruments, and they know your plating system. The A team generally works from 7:30 to about 3, and you want to optimize your operating during that time, because when the B team and C team run around and it's 8 or come in and it's 8 or 9 o'clock at night and they don't know you or your instruments, everything takes a lot longer. Plan your sequence of events and share that with the team so everyone's on the same page. And also plan for breaks and sustenance. Get yourself a snack, use the bathroom, because these are 12, 14-hour cases, and 6, 7 o'clock rolls around and you begin, if you haven't taken a break, you start to feel like you're operating underwater. So we plan our incisions and we try to hide them as best we can, not like this poor guy here who fortunately has a good sense of humor about his scar. I generally do my eyelid incisions first because this is the most delicate dissection. I want to have the sharpest knife, best focus, and least swelling. Then we'll do the coronal and then move down to the face and do any external facial incisions if they're necessary, and save the intraoral incisions for last. Expose all of your fractures. Don't start reducing fractures where you haven't seen fractures elsewhere on the face. Expose all of them and disimpact any fracture that's impacted. Then find your stable bony segments. And in a true panfacial fracture, sometimes this means the zygomatic arch at the skull base or the sphenoid bone in the lateral orbit or the nasofrontal junction. This is what we want to avoid. So our goal is to do an open reduction internal fixation. We want to avoid the OIF, as my former partner, Dr. Gruss, used to call it. And that's when you forget to reduce the fractures, such as was done on this patient in the CT scan shown here. So once you get your fractures reduced, I generally fixate them from outside to inside. So you set your facial width, you set your facial projection, then you set your orbital size and shape. Now, it's okay to bone graft defects if they're truly defects, but you really have to convince yourself that they're truly missing bone and it's just not a malreduction that you're getting fooled by. Once you have the upper face set, then set the occlusion and fixate the maxilla and mandible. Now, this is my general approach, but it's important to be flexible. Sometimes you have a horrible injury such as this, and you just have to kind of make it up as you go. So here's a case to present. It's a 47-year-old who was flown down from Alaska. He was working on a fishing boat and fell, striking his face on the propeller. He has anterior posterior frontal sinus injuries, Lefort 3-2-1 with a split palate, nasal bone and septal fractures, and nasal and palatal lacerations you see on his face here. The things we have in our favor, his zygoma on the left is intact, so we can work off of that. He has a mandible that's intact. We can use that, and he's got pretty good teeth. So we went ahead and took some impressions and made an occlusal splint. We planned bilateral mid-lid incisions, a coronal, gingival sulcus incisions, and we plan to use the hybrid arch bar system. We first disimpacted Lefort 2 and then treated the right ZMC and lateral orbit, then did a frontal craniotomy and harvested split calvario bone graft from the inner table. We cranialized the frontal sinus, bone grafted the medial orbits, and then bone grafted the nasofrontal ducts. Then reduced and fixated the nasoorbital ethmoid segments and placed a MedPore implant to correct the orbital floor defect, and then fashioned a dorsal cantilever bone graft, which was placed through an external rhinoplasty approach, put the patient in MMF, and then fixated his Lefort 1 segment, and then placed an external nasal splint. So I was happy with the reductions, but here's the patient a week later as he comes back to clinic. And this is to make the point that if you don't take care of the soft tissue, then even a great case like this can be ruined by small soft tissue defects. So I put the dorsal splint on a little too tight, and he now has a pressure sore with exposed hardware at his nasofrontal junction there. So had to take him back and close that up. And it's hard to remember this, you know. You've just finished a 14-hour case, you're tired, but you don't pay attention as well as maybe you should for the soft tissue, but it's really, really important to do so. This is not what you want to leave your intern to close. You need to make sure you resuspend the midface to prevent premature aging and to prevent the malar descent pulling your eyelid down. Be really careful when you're closing the eyelids. Patients with eyelid malposition post-op are miserable patients. If you do a coronal incision, close the temporal fascia to avoid that, what we call the mark of neurosurgery, which is temporal hollowing. and be careful to close nicely intraorally to prevent fistulas. In conclusion, panfacial fractures such as these being treated during daylight hours are, I think, one of the best cases in the world to do. The anatomy is challenging, the treatment is challenging, it's a three-dimensional structure you're working with, and you get to work with your team. That being said, panfacial fractures in the middle of the night are one of the worst cases in the world to do. Because of that challenging anatomy, you can find yourself in a downward spiral where you reduce it in one spot and it becomes unreduced in another. And then you get tired and you're tempted to cut corners and you won't get the result you want. But if you do things right, your goal is that your patients only nag you about the small things and the big things are put behind them. Thank you very much for your attention. That's it.
Go ahead, Dr. Rollo.
Great. Can you all hear me? Great. So welcome and good afternoon. I'm going to talk today about a topic that's very important to me, the impact of limb preservation service and the resulting reduction in major amputations. I'd like to thank, in particular, one of our residents, Jake Hemingway, and the entire Harborview team for making this happen. Next slide, please. I have no disclosures. Next slide. So, as you can predict, amputation is a devastating condition. It can lead to psychological and quality of life implications. Many amputations are performed annually, particularly for chronic limb-threatening ischemia in the United States and Europe, and rates of amputations are increasing. Unfortunately, after amputation, less than 2/3 of below-knee amputation patients are actually ever able to ambulate again, and less than half of above-knee amputation patients ever have successful rehabilitation. Next slide, please. And in addition, after a major lower extremity amputation, it portends a very poor outcome for the patient in general. 3-year survival rate, 50%, 5-year survival rate, even less. In addition, many patients undergo a contralateral amputation, 42% within the first 3 years and 56% within 5 years. So it's an indicator of a highly morbid condition, which has resulted in much further trauma for the patient down the road. Next slide. There are many indications for below-knee amputation or above-knee amputation, the most common of which that we deal with are chronic limb-threatening ischemia and acute limb ischemia, as well as trauma, acute infection, chronic infection, diabetes induced in particular, osteomyelitis. Other indications, revision of prior amputations. There are a number of more rare conditions that lead to amputation as well. Next slide. One of the most critical impacts on whether a patient is going to undergo an amputation, particularly in the presence of vascular disease, is whether peripheral arterial disease is ever diagnosed in the first place. Revascularization for treating peripheral arterial disease in the setting of a foot wound or a non-healing ulcer is critical to revascularize that patient and allow them to have the opportunity to heal. And so a number of studies have shown that in patients with chronic limb-threatening ischemia, 51% of patients had no diagnostic vascular evaluation prior to their amputation. Another study revealed that they had over 50% of patients had no vascular procedures in the year prior to their amputation, even patients that have known limb-threatening ischemia. Next slide. CLTI, chronic limb-threatening ischemia, is a very costly condition. 49 million adults over 65 in the United States in 2016, with a 4-year cost of close to $100,000 and $12 billion annually. So it's a very expensive problem to deal with. Next slide. The patients who are beneficiaries with CLTI in Medicare, their healthcare costs were analyzed by Mustafa et al. And after their first intervention, they did a propensity matched analysis of patients with chronic limb-threatening ischemia and actually found a survival benefit in patients who were able to undergo treatment with endovascular therapy with an improved median survival. However, these conditions are in patients with severe multiple comorbidities, so their overall survival is fairly low. However, patients who underwent primary amputation as their first treatment option had the very lowest median survival at 1.3 years. Next slide. In the patients who underwent either endovascular or surgical revascularization, the actual cost associated with that patient's care was lower than patients who underwent major amputation. So primary amputation without revascularization is associated with a shorter survival time and higher risk of subsequent amputation, as well as higher costs. Next slide. So the goal is to limit and prevent amputations by treating the underlying conditions that predispose patients to undergoing this really morbid operation. And so educational interventions are very important, as well as the development of multidisciplinary teams, and that's what we're going to talk a little bit more about today. Therapeutic footwear, just the ability to see a podiatrist or to see a physician that is able to provide a therapeutic footwear for diabetic foot ulcers, can prevent a large number of amputations with extraordinary cost savings. Next slide. So with that in mind, the Harborview Limb Preservation Service was created. It was born out of the prior limb viability service, which was previously under the guidance of PM&R orthopedics with minimal vascular input, minimal vascular interventions, and had a high rate of amputations. The multidisciplinary group was renamed the Limb Preservation Service with vascular surgery leadership. Next slide. There were some growing pains early on, certainly, but they worked with the inpatient wound care service and the trauma service and orthopedics, and identified patients who needed vascular workup, vascular studies, and made it available to them, with the goal of reducing major amputations in favor of minor amputations. And actually, the incidence of minor amputations went up significantly throughout this process. Next slide. So this is a kind of a view of our limb preservation service, and we're meeting here in the Clues room and the vascular surgery division. We meet with vascular surgeons, podiatrists, PM&R, prosthetics, plastic surgery, orthopedics, and infectious disease. We all meet together, ideally pre-COVID, in the same room. Now we do it over Zoom, but we discuss difficult patients, discuss our pathways, and plan for future changes and interventions, as well as identify problem areas where patients aren't getting the care that they need. Next slide. We have quarterly meetings and try and standardize our approach and disseminate new information. Next slide. So what effect did this have on amputation rates at particularly at Harborview? As well as I'll talk a little bit about Northwest Hospital as well, to which I arrived in 2017 and brought the LPS approach to Northwest. Next slide. So we did a retrospective review here of all of our major amputations between 2009 and 2018. There were two cohorts, pre-LPS and post-LPS, with studying major amputations, that's below knee or above knee, and revisions. Next slide. So there were 609 major amputations in the total study period, 490 pre-LPS and 119 post-LPS, with an overall reduction of 76%. The distribution of surgeons that performed the amputations changed somewhat in that time period, but orthopedic surgery performed the majority of amputations in general. Next slide. So in the LPS era, there was a very high mean Rutherford classification, meaning the severity of peripheral arterial disease was very high at 5.5, with the max being 6, and very high Wi-Fi score, which is an indicator of overall the risk of amputation with regards to the wound, infection, and and ischemia. Acute limb ischemia is also a major problem that leads to amputation, which was quite prevalent in this cohort study. But all patients with acute limb ischemia had attempts at limb salvage prior to amputation, which was a difference compared to the pre-LPS era. Next slide. And so this is our graphic display of the results. As you can see, the red line marks the time point at which limb preservation service came into fruition, and a nearly immediate reduction in overall amputations throughout the following years to a point where between 20 and 40 major amputations are done at Harborview Medical Center per year, compared to many more in the previous era. And if you look at the reduction of major amputations by indication, all indications showed significant reduction in major amputation, particularly chronic limb-threatening ischemia, acute limb ischemia, and trauma. These areas showed dramatic reduction in amputations with the implementation of our limb preservation service. Next slide. You can click through those numbers. It just displays the reduction in total amputation by percentage. Additionally, at Northwest Hospital, our reduction in major amputations was approximately 50% in the 2 year, compared to the 2 years before I arrived in October 2015 to 2017, comparing to the more recent 2 years, over 50% reduction in major amputations, with really no change in the patient population. The only difference was the introduction of intensive vascular therapy, intensive vascular interventions, and a surgical podiatrist, as well as a change in mindset of how to manage these patients and to maximize revascularization. So a major reduction in amputations. Next slide. And by indication, the total amputations done by indication at Northwest Hospital in the most recent 2 years, 6 patients for CLTI. The majority of the amputations in the last 2 years are done for neuropathy and osteomyelitis, so as well as acute infection. So chronic limb-threatening ischemia, of which we see a large number of patients here, over 160 interventions for chronic limb-threatening ischemia in the last 2 years, only 6 amputations as a result of that disease process. Next slide. So lessons learned, a decrease in overall all-cause major amputations, significant reduction in cases that are due to limb-threatening ischemia. We implemented protocols for the emergency department, medicine, and wound care to expedite evaluation of peripheral arterial disease, expedite referral to a vascular surgeon for revascularization, as well as maximize the management of diabetic foot ulcer patients, of which we continue to have ongoing changes in protocols in order to expedite and maximize the care of patients with diabetic foot ulcers. It's an ongoing concern, and in order to prevent those ending up in major amputation. High quality wound care is also an essential part of that, and particularly at the wound care center that I work with here at Northwest is fantastic, at UWMC North. Obviously, a goal of 0 amputations is unrealistic and likely not possible, but reducing the major amputations to a level of where it's only done when it's essential is the goal. Next slide. Vascular specialist leadership is essential here. Surgical podiatrist, particularly one with awareness of the problems associated with arterial insufficiency and how to evaluate that is essential. Algorithms for referral, and of course availability. Having a vascular surgeon with the proper skills and techniques that's available to perform these interventions is essential. Next slide. So in conclusion, have a great team, be available, build bridges. We're not shooting for 0 amputations, we're shooting for only necessary, absolute amputations that are absolutely necessary. The value of a limb preservation service extends well beyond vascular disease. As you can tell, there's a dramatic reduction in patient requiring amputation due to trauma or other causes. Next slide. So we're going to be looking to expand community primary physician and wound care outreach over the next few years, develop system level and patient level cost analysis studies, as well as single center comparison of amputations pre and post intensive vascular intervention. So with that, I will conclude. Thank you.
Thank you. Dr. Burke.
All right, thank you. Good afternoon, everyone, and thank you for the opportunity to present. I'll be discussing aortic valve preservation surgery this afternoon, and I think the reason for the asterisks will become apparent. Next slide, please. No disclosures. So a little bit of historical context. In the past 30 years or so, there's been tremendous refinement in mitral valve repair techniques for patients with mitral regurgitation. And mitral valve repair is now the standard of care for severe symptomatic patients with mitral regurgitation. And despite that, the treatment of aortic valvular disease continues to center around aortic valve replacement. Go ahead, next slide. And aortic valve replacement is a very well established and reproducible procedure. It can be done obviously by any cardiac surgeon. It allows us the ability to place either a mechanical or a bioprosthetic valve. Mechanicals having more durability, but requiring anticoagulation versus a bioprosthetic valve, which does not require long-term anticoagulation, but does wear out over time. It tends to have a quote-unquote lifespan of about 10 to 14 years. The introduction of TAVR, or percutaneous aortic valve implantation, has proven to be a very disruptive technology. And because of that and the ability to do valve-in-valve TAVRs with pre-existing bioprosthetic valves, we've seen a tremendous increase in bioprosthetic aortic valve replacement. And we're starting to learn what the consequences and sequelae from that changing trend in the past 5 or 10 years. Valve replacement, however, does result in future morbidity and excess mortality, and this is especially true in the young patient. Next slide. So this data just highlights the excess mortality that's observed after aortic valve replacement compared to case match controls. Next slide. And this data is even more important. The study looked at mechanical aortic valve replacements, which are the valve choice, preferred valve choice in young patients. So this looked at patients less than 65 years and followed them for, next slide, an average of 9 years. Next slide, please. And again, looking specifically at young mechanical aortic valve replacement patients, you again see this excess mortality. And these patients fall off the survival curve as compared to case match controls. Next slide. Next slide. And this is perhaps the most striking feature of this data. Go ahead, next slide. That at 10 years, 1 in 5 patients is either dead or reoperated upon. And I think this is extremely important data for us to understand as surgeons. These are young patients getting mechanical valves where we often feel as though the promise is these won't wear out and these should quote unquote last forever. Go ahead, next slide. So in terms of specifically focusing on patients with aortic insufficiency, again, aortic valve replacement is associated with excess mortality, true in mechanical AVRs, and this is especially true in young patients. And aortic valve repair allows for the restoration of the living aortic valve complex and potentially decreases the long-term morbidity mortality seen with valve replacement, similar to what we've seen in mitral valve repair. And this does not require anticoagulation, which is very important. And we think that these repair techniques are durable. Next slide, please. So in the past decade or so, there has been a tremendous increase in aortic valve repair. Many different techniques have been described. We'll go through some of them today. Most of this literature is coming from Europe, and so far we've seen good medium-term results repairing both tri-leaflet and bicuspid valves, again with aortic insufficiency primarily. Next slide. The principles of aortic valve repair are actually very similar, no surprise, to mitral valve repair, and really center around the concept of an annuloplasty along with a valve leaflet repair. And annuloplasty is just the reduction in diameter of the aortic annulus. This can be accomplished in a variety of ways. There's external and internal annuloplasty rings, which we'll go over, along with valve-sparing root replacements. And in terms of leaflet repair, there are many, many different aspects to this. The most important and common is what are called leaflet plications, and we'll see an example of that to raise the leaflet height and increase coaptation. Next slide. So there's some emerging technologies, including this internal annuloplasty ring called the heart ring. This is extremely similar to annuloplasty rings that we use in the mitral or tricuspid position. These come in both tri-leaflet configurations along with bicuspid for patients with bicuspid aortic valve insufficiency, and really allows reproducibility of these repairs. Go ahead, next slide. So this is a video of a 75-year-old woman with a 5.5 centimeter ascending aortic aneurysm. She has moderate to severe tri-leaflet aortic insufficiency, shown there preoperatively. The valve is assessed. The aortic annulus is measured. And we use these ring sizers to select the size of the annuloplasty ring. We start by placing the commissural sutures, and these will be passed through the posts on the annuloplasty ring. The ring is then lowered below the valve leaflets into the aortic annulus, and multiple anchoring sutures to prevent dehiscence or migration of the ring are placed. And then these will get tied down. This patient had some fibrosis of the nodules at the midpoint of the leaflets. This is just the CUSA ultrasonic device, reducing those. This is a leaflet plication. There was some prolapse of the non-coronary cusp. Again, this will raise the height of this leaflet. And then there'll be a second plication of the left coronary cusp, which has a little bit of excess surface area, which I'm doing right here. This was the first time that we used this technology in a patient here at the University of Washington. Now used it on several patients. The result is assessed. We have good coaptation, appropriate leaflet heights, and the postoperative echo shows essentially no aortic insufficiency. Importantly, the gradient is nice and low. We haven't created stenosis. Next slide. So then what about aortic root aneurysms? These are classically treated with what's called a Bentall procedure, where both the aortic root and the aortic valve is replaced. Next slide. However, valve-sparing root replacement procedures have become more and more commonplace. And this is a much more elegant operation where the patient's own aortic valve is salvaged and sewn within a Dacron graft. And it's really now standard of care at the University of Washington for root aneurysms when the aortic valve is repairable. We use it in a variety of settings. Aortic insufficiency, I've done several patients with type A dissections, along with bicuspid patients. For some context, I did 2 of these procedures in training, and we're on pace to do between 25 and 30 this year. Next slide. Just a brief video showing a David 5 or a valve sparing root replacement. This is a young gentleman with a 5.5 centimeter root aneurysm. This is a perfectly normal aortic valve. There's a little bit of aortic insufficiency. As with any root replacement, we start by mobilizing the coronary buttons. Here we're mobilizing the left coronary artery. This is one of the more critical aspects of this procedure. We're actually doing what's called the subannular dissection. We're dissecting the aortic root here off the heart. And this is really the only time in cardiac surgery that we do this dissection, and you have to be a little bit meticulous here, but we're getting below the level of the aortic annulus. It's a beautiful valve. The annulus is sized. You can see a 29 millimeter dilator shown there. That helps us choose the size of graft we're going to use and the amount of annular reduction we get. The subannular sutures are placed. These will go through the Valsalva Dacron graft to help anchor the graft. And then the Valsalva graft gets sutured to those anchoring sutures. Again, being constrained within that graft is what reduces the size of the annulus. We now suspend the aortic valve commissures within the graft. And then our aortic suture line is performed. This is the hemostatic suture line. So we go through all 3 cusps in the case of a trileaflet valve. A leaflet plication here was needed on the non-coronary cusp. There was a little bit of prolapse. So again, we can do leaflet repairs on top of the annuloplasty that we got from the Valsalva graft. And again, that raises the height of that leaflet to help with coaptation. So the coronary buttons will be next. We do a little graftotomy and attach the coronary buttons. This is the left coronary button going first. And this obviously gets repeated on the right. And then we make our final valve assessment. So that's a 25 millimeter dilator going in. So we've reduced the annulus. We have excellent coaptation of those leaflets. They're all coming up at appropriate height. And we have absolutely no aortic insufficiency at the end of the case. Next slide, please. So the traditional aortic insufficiency algorithm is straightforward. Next slide. Aortic valve replacement. Next slide, please. But we've really worked on a novel aortic insufficiency algorithm here that centers on valve sparing root replacements when patients have aortic aneurysms, or sorry, root aneurysms. And then in the absence of root aneurysms, pretty much any patient deemed to have a repairable valve, we go ahead and aggressively try and repair those valves. Next slide, please. I'm going to take a minute or two and just finish with aortic stenosis. So in general, aortic valves with significant aortic stenosis are not repairable. This is a bicuspid aortic stenosis case I did a few weeks ago. And you can just see the amount of calcium in that valve, and there is really no way to salvage that valve or repair that valve. Next slide. So more and more in younger patients, there's been a renewed interest in what's called the Ross procedure, whereas it's a procedure to replace the aortic valve where we actually take the patient's pulmonic valve and move it over to the aortic position and then reconstruct the pulmonary outflow tract with a cadaver homograft. Go ahead, next slide. And the renewed enthusiasm for this case, for this technique is shown here. I won't spend a lot of time on this, but more or less there's good data to suggest that patients after a ROS don't suffer the mortality deficit that's seen with aortic valve replacement, and actually fare similar to case match controls. And the figure on the right actually compares ROS procedure to mechanical AVR, again, sort of our traditional go-to for younger patients. You can see much better freedom from cardiac and valve-related mortality in ROS patients. Next slide, please. There are some disadvantages. The ROS is a more technically complex procedure, there's potential for failure of 2 valves, and the reoperations can be quite complex. So this is not for every program and not for every patient. Go ahead, next slide. Just briefly, you might need to hit the forward arrow. This is a young patient we did who had a very abnormal aortic valve, shown on the left, who got a ROS procedure. It's a beautiful result. This is a young woman who does not have to worry about anticoagulation and should have an excellent result from this. Go ahead, next slide. In terms of how we're thinking about aortic stenosis these days, it really depends on age. If a patient is less than 55 years old, we're really thinking and discussing a ROS with all of those patients. It is a nuanced shared decision making that we have to make with those patients, but it is something that is on our radar and is within our armamentarium. Next slide. So in conclusion, I think it's very important as cardiac surgeons that we recognize that aortic valve replacement has consequences, and patients fall off a normal life expectancy curve with that. And I believe that retaining the living aortic valve complex with either valve repair or a ROS procedure has tremendous value in properly selected patients. Thank you, and be happy to take any questions.
Thanks, Chris. One question I had prepared was, besides the obvious benefits of avoiding lifelong anticoagulation, are there any other significant differences in quality of life for these young patients between the different procedures, as far as direct head-to-head study comparisons? And secondly, many of our patients are increasingly being placed on different biologic therapies for a variety of medical conditions with really minimal to no data on wound healing. Do these newer drugs impact your decision-making in selecting these procedures?
Thanks, Dr. Wu. So in terms of the first question, so the only really direct, so aortic valve repair and, for example, those annuloplasty rings I've shown, this is very, very new. And so we frankly don't even have long-term data for those patients. We certainly know that if you can extrapolate from mitral valve patients, mitral valve repair is superior to replacement. And mitral valve surgeons will repair mitral valves all the way out to patients in their 80s, quite frankly, for a variety of reasons: valve degeneration, endocarditis risk, anticoagulation in place of mechanical valves. It remains to be seen how that holds true in the aortic position. And honestly, the interplay of TAVR is very, very important in the future. I think in thinking of younger patients, the issue of anticoagulation, especially in young women, with the issues of Coumadin and pregnancy, are really important. We still are really confined to Coumadin for all of our mechanical valves. That could change. We're actually participating in some clinical studies looking at alternatives to Coumadin, but regardless, as of now, we're stuck to Coumadin. And all those issues exist with reinterventions, endocarditis, et cetera, et cetera. So I think many of the things we've seen in mitral valve, I think will apply to aortic valve. And again, there has never been a good randomized study looking at ROS in mechanical AVR. That would be great. But again, if you just look at sort of head-to-head and compare outcomes for those patients, it seems like patients who receive ROSs do better. Now, there's probably, a lot sort of confounding there, but regardless, that is the data that we have available.
Thanks. And Dr. Rollo, it's remarkable that reorganizing a multi-specialty group under new vascular leadership, resulted in such a dramatic reversal in amputation rates. Shouldn't this just be the standardized model for everyone everywhere? And now during the pandemic, has that impacted or affected the changed the effectiveness of the group at all?
Yeah, that's a good question. I think that it should be the standard model for every major institution. The problem is availability of resources, particularly availability of vascular surgery resources, and as well as surgical podiatry. Those two services are really critical to improve limb salvage rates. So if a hospital system doesn't have that, then they should be referred to a place that does. However, what ends up happening is that then the patients end up waiting to get that care, and then they end up with amputations. So it's certainly ideal to have a setup like ours where the vascular surgery and podiatry and orthopedics and infectious disease all work together to make this happen. It takes a multidisciplinary team to make that work. With regards to the pandemic, there's really I think there was initially some delay in care where patients would not see physicians for their wounds that led to some delays in establishing their care. But we quickly caught up with that once we were able to resume elective procedures, but it certainly had some effect on our volumes, without doubt.
Well, it's great. It's great work. I see on our chat board, Chris. Chris had answered the question. Great. Well, I want to thank everyone for again for their talks, and most of all to Ellison and Savannah for keeping this all going. We had some trepidation and worries if something would happen during this talk, but we were able to get through this whole symposium. So Ellison, Savannah, thank you very much. We went over a little bit of time. We are going to have the Strauss lecture at 4 o'clock. We do have a separate link, so this won't be the same link. So everyone please refer to the separate link that was provided in the email before. Doug, any statements or anything to close with?
Yes, I do. Thanks for giving me the chance. So besides the thanks to Ellison and Savannah, which is appropriate, Peter, thanks to you. Thanks for organizing a great session. I always come out of this both proud and humbled, proud of the people here that I get to work with, and humbled at how smart they are, because it makes me feel less smart. But this is a great session and incredibly put together, Peter. Really a wonderful work from our faculty. Really appreciate Dr. Cornwell being with us for the morning here. Eddie, I know it's already now well into the afternoon where you are, and thank you for taking it into the evening for us for your lecture. And I really want to encourage everyone to be back at 4 o'clock with a due link, because I think we have a great 71st Alfred A. Strauss lecture coming from Dr. Cornwell this afternoon. So thank you for a great morning, for a great Harkins Symposium.
Thanks, Peter. Thank you.
And we'll see you later this afternoon.